You could please make sure your cell phones are turned off or to silent. Hey, Alpha. You can do it now. Play the video.
Met my wife in 1987, and she was first diagnosed at age 30.
I am a stage 4 breast cancer, metastatic breast cancer patient.
Me dio cáncer de mama y en los huesos.
Sometimes people are re-diagnosed at a later stage, but I was initially diagnosed at stage 4.
When I was told my breast cancer was stage 4, I said, and what comes after that? Yeah.
Metastatic breast cancer is advanced breast cancer that has spread to other organs in the body.
Something I never thought I would have.
Porque solamente uno sabe lo que siente cuando tiene esa enfermedad.
Pain and fatigue daily.
Metastatic breast cancer is awful.
Is not curable yet.
Metastatic breast cancer is not an obvious condition. Yeah, I'm sick. May not look like it, but got cancer.
Managing metastatic breast cancer means being your own best advocate.
I think it's important to truly be an advocate for yourself and really do the research to find out what your options are.
I want this story to reach other kids and young adults who have a mom or a family member that has metastatic breast cancer. Anyone who needs a glimmer of hope who is maybe facing a metastatic diagnosis.
There's a breast cancer book out there, and stage 4, it always talked about death and the possibility of losing your life. Throw that chapter away. There's always hope out there and treatments available, and with the stuff that's currently coming out, it really does give hope for people that have metastatic breast cancer.
Metastatic breast cancer is different for everyone.
Everyone.
Everybody.
Para todos.
You want a cure?
More research, more support.
Y más tiempo.
And more time. And more time.
And more time.
Learn more at colemanchicago.org/MBC.
Thank you so much for joining us today. I'm Bonnie Gordon, Executive Director of Susan G. Komen Chicago. And we are just grateful you're here at our first annual, I'm going to say annual because I mean annual, Metastatic Breast Cancer Conference, Time for Metastatic Perspectives. The video that you just saw was made possible by Pfizer through its partnership with the It's About Time campaign. And on a personal note, I just want to say thank you to Kati Petridis and to Jasmine Johnson, who were really the impetus for helping us get to where we are here today. So thank you so much. As you know, Komen has set a big, bold goal to reduce breast cancer deaths by 50% by 2026. Metastatic disease is responsible for more than 40,000 deaths across the U.S. each year, and that has to stop. I wanted to introduce Amina Abdullah, who is our Director of Community Programs at Komen Chicago.
Thanks. One of the ways that we plan to reach our big, bold goal is to invest more in research and to also provide more education and quality resources to those living with the disease. So we heard you loud and clear. More research, more support, and more time.
So, again, thank you for being here. This is the first of many. This will be something that we will take on, and we are just really proud to have this happen today. We want to introduce our, and I'm just looking right where she is, our volunteer chair, who is also living with metastatic breast cancer, our friend who, again, really, I have to say, just helped make this all happen. Robin Page is here, and we're just proud to have you here.
Hi, my name is Robin Page, and I'm grateful for your presence here today. I'm a thriver going on 10 years of living after metastatic breast cancer diagnosis in 2008. My drug treatments included Herceptin and Abraxane. 7 months after my initial diagnosis, I had a CT scan that showed no evidence of disease. I was searching for answers about whether to have surgery and when or if I should stop Herceptin. A family friend who was a member of the Board of Trustees at Johns Hopkins arranged an appointment for me to meet with Dr. Ben Park as a second opinion. I didn't know what to expect at that first visit, and I surely didn't expect to be introducing him here at this meeting all these years later. Dr. Park gave me his full attention at that appointment. He was thorough and honest with his evaluation, explaining his rationale, and helping me make the ultimate decision to proceed with a bilateral mastectomy. Several years later, I stopped Herceptin without return of disease. I'm honored that I was able to interview my healthcare team, including Dr. Park, for a project that I'm working on. The interview pertains to their perspectives on mindset, nutrition, supplements, and seeing a cure for metastatic breast cancer. At the end of our interview, he said, "You are my you are my success story. I tell many people about you." And I said, "Not to be outdone, you are my favorite physician, and I tell more people about you." So that is why I'm here today, to tell you about this humble, hardworking physician and researcher who is determined to extend the lives of people living with breast cancer. Ben Park graduated from the University of Chicago with honors, then completed a dual MD-PhD training program at the University of Pennsylvania School of Medicine. In 2002, Dr. Park joined the faculty as an assistant professor of oncology at the Sidney Kimball Comprehensive Cancer Center at Johns Hopkins, where he is developing new therapeutics and diagnostics for breast cancer using genetic-based approaches. He is currently professor of oncology in the breast and ovarian cancer program at Johns Hopkins and the associate dean for postdoctoral affairs. Dr. Park is among the distinguished scholars and leaders in breast cancer research and advocacy who are serving as a Komen Scholar. Komen is privileged to have Dr. Park here to be part of this valuable and crucial conference, Time for Metastatic Breast Cancer Perspectives. We believe in the work that Dr. Park is doing to change the outcomes for breast cancer. He continues to change my perspective on living with metastatic disease. He's going to speak with us today about drug resistance and his research on liquid biopsies. So please join me in welcoming our distinguished speaker, Dr. Ben Park, to the podium.
Well, it is really an honor to be here, and I thank you all for coming. I was talking to Robin and her husband Mike outside. This is actually the first time I've been in Northwestern Hospital, believe it or not. I've visited Chicago almost annually. Many of you probably know we have our big ASCO, American Society of Clinical Oncology meeting here every June. And being a Chicago alum, don't hold that against me. I know there's a crosstown rivalry between Northwestern and Chicago, but that's on the south side. So I didn't really get to come up here much when I was growing up, so to speak, in college. So again, it's beautiful here. It kind of makes me wish I would have done my training in the north side of Chicago rather than the south side. But be that as it may, thank you once again. So my talk's going to be a little bit about the liquid biopsy, but more about some newer stuff that we're working on, and really what Komen has actually been funding our lab recently, and as I became a Komen Scholar last year. And so again, this slide is kind of the sobering statistic that I think we all know in the room. There's about 250,000 cases diagnosed in the United States of breast cancer, just again annually. The majority of these cases will be cured because they're early stage. However, as we just heard, over 40,000 women will actually succumb to this disease, and men, I should say, women and men. So early stage breast cancer is curable. This is what we like to tell patients that are the goals of therapy when we find someone diagnosed with early stage disease. However, in contrast to that, and as you just heard, metastatic disease is not curable. It can be treated, however, and in many cases our goal is to turn this into a chronic disease. I like to use the analogy of what insulin has done for diabetes. We don't cure diabetes as a medical field, but we actually can control it. Now, we're not quite there yet, obviously, for most women with metastatic disease, but I put that asterisk in there because that reminds me always of Robin. You know, how do we define cure? What are our metrics for cure? Is it just no evidence of disease? Is it someone who's actually been without disease for a decade or more? we don't know the answer to that question, but Robin actually and others now that I've met really make me believe that some women out there are actually cured of their metastatic disease. Time will tell if I'm right or wrong, but I do think that this is now something that is not only possible, but is even happening before our eyes, albeit at a very small number of patients for right now. So one of the things that I kind of believed in growing up, and I still do, is that if we could understand the genetic underpinnings of what cancer really is, including breast cancer, obviously in my case, then we might be able to exploit those findings for therapeutic and diagnostic purposes. What we've learned over the past 15 years, though, is that not only are different cancers unique in their mutational signature, so all of our cells have DNA, and eventually when those things go awry, that is the DNA, that's what leads to cancer. But we have something like 3 billion DNA molecules all strung together, and everyone's is a little bit different. And so there are some cancers, like colorectal cancer, where the majority of cases, or people who get those cancers, will have a common gene mutation. In breast cancer, it turns out that that's really not the case. And then we've actually found now with receptor subtyping that breast cancer is very heterogeneous, and even amongst the different receptor subtypes. So we know one gene called TP53. This is actually mutated in the majority of triple-negative breast cancers, in about 80 to 90%, but not all. This is a gene that's been a little bit elusive, or a lot elusive really, in terms of finding drugs against the mutated form. People have been working on it, we're still working on it, but until that day comes, this gene gives us a lot of information about a patient's cancer, but we still don't have a lot of therapies directed against that. So again, that's in triple-negative breast cancers only. P53 or TP53 really is mutated at lower frequencies in other breast cancers, but again, not the same rate as triple-negative breast cancers. So where do we go from there? We already know about Herceptin and HER2 and now Perjeta for HER2-positive disease. We have a lot of drugs for ER-positive breast cancer. We still don't have a lot of targeted therapies for triple-negative breast cancer. And when we started to sequence everyone's breast cancer on an individual basis, again, the sobering fact is that everyone's breast cancer is a little bit different. So how do we think about, well, curing breast cancer? I think the paradigm has gradually shifted over the years. When I used to write grants, if I was going to study a gene that was mutated in only 5% of breast cancers, in 2002, people would have laughed that out of the room. In fact, trust me, they did. Ouch. But at the same time, over the last 15 years, now what we understand is, in fact, this is a paradigm that is actually doable in terms of finding mutations at low frequency if we can get really, really good drugs. And lung cancer has really been the poster child for this. We now have a whole kind of armamentarium of targeted therapies for lung cancers with mutations that are a frequency of maybe 1 to 10%. And yet, if you actually have one of those mutations, the results can be pretty dramatic. And that's the question that I've been asking the field. Can we do this for breast cancers? Yes, it may not affect every breast cancer right now, but if we start thinking breast cancers as one at a time, eventually I think we're going to get there. This is also what I would call a living proof of this. There's a rare type of breast cancer, and this is probably one many people have never heard before, called juvenile secretory breast carcinoma. As the name implies, sometimes this occurs in kids or children as well as young adults, and it's usually just treated with surgery and cured. It's there, a mastectomy usually will be the curative regimen. But every once in a while, it'll be either not properly diagnosed or not properly treated, and it can actually metastasize. And this is a cancer that is not actually chemo or radiation sensitive, so there's really not a lot we can do once that happens. Now, that was about 15 years ago. There was a report that I happen to remember that was in a pretty prestigious journal that actually showed what are the molecular underpinnings of this rare type of breast cancer. And it's highlighted here. There are two genes. Genes, again, are DNA, are bits and snippets of DNA that encode for all the different proteins in one's cells and therefore our bodies. And in this particular type of cancer, these two genes get inappropriately put together. So we call that a translocation. Now, this little girl was from Bangladesh. They didn't have a lot of healthcare opportunities there, so she actually got onto a trial of a new drug that was a trial being run out of colleagues from Memorial Sloan Kettering Cancer Center up in New York. And this has actually now been published, as shown here. This is the tumor when she got here. It took a few months to get her visa and her passport. I don't know if you can appreciate that's her chin, but this is now her third recurrence. And I actually didn't see this because she went straight to New York, but I did get her pathology slides and I submitted them for all the molecular analysis. And she got on this clinical trial, which happens to be a company that I sit on the scientific advisory board of, and it's called a pan-TRK inhibitor, TRK. And again, if you saw the previous slide, we know that this is, again, a fusion of this gene and NTRK3. So this drug hits anything that's NTRK1, 2, or 3. That's why we call it a pan-NTRK inhibitor. I think you can appreciate, even after 6 days of just taking this pill daily, the tumor starts shrinking, and by 2 months, it's completely gone. And almost no side effects. If you look at her CAT scan, that was her tumor when she came in. It's completely gone by day 60. This is the lung windows, as we call it, and all those white dots are metastatic lesions that have now gone away. These are blood vessels. And so this patient is now back home popping a pill every day and doing fine. And this is someone I am convinced would have died if not for serendipity. I'm not very religious, but I actually do think there was some divine intervention going on here, because I think the real remarkable part of this story is the fact that we actually have now this drug. This was just published a few weeks ago, larotrectinib in TRK fusion positive cancers in adults and children. And again, the backstory that doesn't often get told about this is how we found this patient. So this is all through the efforts of a colleague of mine at Massachusetts General Hospital. He has a virtual tumor board where he has allied himself with middle, low-income countries, and we actually have a monthly tumor board that's literally through Google Chats, or the business version thereof. So we just are on the internet. It's almost like social media or Facebook, but it's for a global virtual tumor board, and we get these cases every month that they want kind of the expert opinions of thought leaders in the United States. And then again, I happen to be on this scientific advisory board, so it was just weird, because being the person who also had the scientific background on this tumor board, I had heard about these breast cancers from 15 years ago in terms of what the molecular underpinnings are, as well as being on the scientific advisory board of this company, knowing that this trial was going forward. So as luck would have it, this is everything was at a perfect confluence. Donald Trump wasn't president yet, and so getting the visas wasn't that difficult at the time. I'm sure it would have been a different story. And this is really the global tumor board as depicted here in this graph, with the US and other international centers. So to me, that was a really remarkable, again, coincidence, confluence, whatever you want to call it, divine intervention, that this one girl's life we could actually save. And I use that term very, very cautiously, but I really do feel like this was a girl who surely would have died had we not intervened. And to me, this is as close to a miracle in medicine that we're ever going to get. So I wanted to share that story, and with that, take you through another story that, again, our Komen funding is sponsoring right now, targeting rare mutations in breast cancer, as I was saying earlier. Now, just to backtrack again, all of our bodies are made of trillions of cells, and the majority of our cells in our body have DNA. DNA is the blueprint, so the DNA actually makes proteins, but it does it through intermediate steps. So a gene is really just organized units of DNA, and they usually have these things called exons and something called an intron. And the DNA is really, again, just a template. It doesn't physically do anything in terms of making stuff for our bodies, but it serves as the templates for making RNA. So even though this looks identical, this is DNA and now this is RNA. And RNA by itself has to go through several processing steps. This will all make sense later. I know you're probably thinking, why the heck is he talking about this? But RNA gets these types of protein complexes called spliceosomes, and that will actually take out this intervening intron sequence, because in order to get a protein, you got to get rid of that. The mature RNA has to get rid of the intervening sequences called the introns, and it relies upon spliceosomes to do this in a very precise manner. And that's how you get a protein. Again, why am I telling you all this? Well, it turns out these things can get mutations. And again, this is critically important to make a normal protein. And so it turns out that these spliceosome proteins, which are also encoded by genes, which makes sense, get mutations in them. And it turns out that in most of the cases, these are mutated with relatively higher frequencies in blood cancers. So diseases we call acute myeloid leukemias or myelodysplastic syndromes, et cetera. And then in lower frequencies in some solid tumors, including breast. And I highlight these particular numbers and letters because those are the areas of the protein. This is the 700th amino acid of that protein. And it's usually a K, and then it gets changed to an E. That's the alphabet for protein. When we see this again and again across cancers, we call these hotspot mutations. And that actually tells us statistically these aren't just happening without reason. They're being selected for. They're clearly giving the cell some sort of growth advantage or cancerous advantage. And that's why we see them at some frequency, and hence the name hotspot mutations. So even though, as I was telling you, P53 comprises 80 to 90% of triple-negative breast cancers, across the board, 3% of breast cancers will actually have spliceosome mutations, and this particular hotspot K700E. Now again, 3% doesn't seem like a lot, but when you think about what we do in oncology, 3% is a lot of patients for breast cancer patients. You know, we're talking tens of thousands of lives. And so that's not an insignificant number. Some of our earliest efforts for chemotherapy, as an example, improve cure rates after surgery by about 5%. But because of the risk-benefit ratio and because of the denominator, 5% again representing tens of thousands of lives, that's not an insignificant number. And then also, to go back to the lung cancer analogy, sometimes you can make dramatic differences in that small percentage of patients. So we decided to actually think about this and study this. One of the things that we and others have been thinking about with these spliceosome mutations is what happens when you have them. And that's been pretty well characterized nowadays, that in a normal cell, I just showed you what happens. But in a cancer cell, what ends up happening is that intervening intron sequencing doesn't get completely cut out. And some 2/3 of the time, because of the nature of how RNA gets changed into protein, that doesn't really have any consequence. But 1/3 of the time, you can actually see an aberrant protein being made because that intervening sequence is retained, and that gets actually changed or translated, we say, into the protein itself. Now again, why is this important? Why is he telling me all this stuff? Well, one of the things our lab likes to do is actually do what we call now gene editing, so we can really understand what is the effect of a single mutation. So we take normal human breast cells in the lab, and we introduce a mutation that we find in cancer to see what is the effect. That way we can compare directly what is the effect of the one introduced mutation to the parental cell, which is normal. And we do this and we study various aspects of those cell lines. We call them isogenic because they're otherwise identical except for the presence or absence of a single base pair change or DNA base pair change. And so people have studied this in some context, not really in breast cancer before, but we wanted to make sure, hey, does this actually change the RNA editing, as we would call it? And so you can do these very simple experiments that once you created these cell lines, we harvest the DNA, we harvest the RNA, and we study it. And you can run these tests, they're DNA assays. We just measure the length of the DNA. And if you actually have an RNA molecule here that retains this intervening red sequence, you'll get a higher band, we call it on a gel, and the correct sequence will be here. So we were pleasantly surprised because most things in science, believe it or not, are not very reproducible. I know that's maybe shocking to some of you, but there's an ongoing effort right now from many journals and the NCI and the NIH to see how reproducible are people's data. It turns out we're not very good at this as scientists, which I know sounds scary, but there are a number of good reasons for that. But suffice it to say, we were pleasantly surprised because every single gene we looked at that was predicted to have an additional, now new aberrant or cryptic transcript, as we call it, or mRNA, in fact did have that. And we did this in one cell line and another. Again, these are normal human breast cell lines, and they have the capacity to turn into cancer, or we can turn them into cancer with the mutations that we introduce. But we also went a step further because we really wanted to make sure, are these things making proteins? And that becomes important next. And it turns out with help from collaborators at Hopkins who are proteomics experts, in fact, we showed, and this hasn't been published yet, but soon will be, that these aberrant RNA species can in fact make aberrant proteins. All right, I'm going to take a half step back. Rita Nanda, I think, is going to be here, and she's a world's expert in triple-negative breast cancers with immunotherapies. But I'm going to hopefully not steal too much of her thunder and explain to you exactly how this works. So who in the audience have heard of immunotherapies? Probably a lot of people these days. Yeah, pretty much everyone. This is one of the greatest things. You know, I actually was a PhD immunologist at Penn, and part of that was because at the University of Chicago, I studied in a tumor immunology lab. And I like to tell the story that at some point I gave up on immunotherapy because I just thought, this is too hard, it'll never work. And thankfully I was wrong, but now many, including my lab, are getting back into immunotherapies because of the excitement and the potential opportunities. The problem with immunotherapies right now is that they work for some cancers and they don't work for many others, including breast cancers. Even the best responses, as Dr. Nando can tell you, we don't get a huge percentage of patients that respond to these immunotherapies. But what are these immunotherapies? So putting in very simplistic terms, when you have a cancer cell, there's some aberrant protein that can get recognized by an immune cell. Usually it's the T cell. And so there's this interaction between what we call the T cell receptor and the antigen. That's the protein that the T cell is trying to recognize. However, if you think about it, cancer is the result of our own bodies. And our bodies have been trained, or our immune systems have been trained not to attack ourselves. When that isn't well trained, that's how we get autoimmune diseases, and those can actually be very, very serious. So there are a series of what we call checkpoints, including this very important one called PD-1 on the T cell and PD-L1 on our normal cells, which again, even though cancer is not normal, it was derived from normal, so it's going to express this. And it says, hey, don't attack me. I'm you. You shouldn't attack me. So the idea behind what we now call immune checkpoint inhibitors or immunotherapies is that we have antibodies that can block either this or both, and it prevents these guys from shaking hands so that this interaction then sets off the immune system. Now, I wish it were that simple. It turns out, remember, cancer is ourself. And so there aren't many tumor-specific antigens, right? Most of these things that are being presented are, in fact, our normal proteins, just like they are from our normal self or cells. So when we do see this happen, that must mean that, in fact, that protein must be a little bit different. Well, how could that be? Mutations. Remember, I was saying DNA is mutant, and mutant DNA will eventually lead to a mutant protein. So people started looking at the different types of cancers that had good responses, melanoma and certain types of lung cancers, and they started doing genetic sequencing of those cancers, and they found something that we now call tumor mutation burden. And it turns out the more mutations a cancer has, the higher likelihood that this strategy will work. Now, if you liken this to playing the lottery, the more lottery tickets you buy, right, the higher the likelihood that one of those or more will be a winner. And so the thought process of this is that the more mutations a cancer contains, the higher likelihood that any one of those mutations are going to be in genes that are going to lead to a protein that's going to be recognized as something foreign. And so my former mentor and colleagues at Hopkins tested this theory in a clinical trial. Bert Vogelstein is a world-famous cancer researcher, and I trained in his lab some 20 years ago. And he actually discovered in colorectal cancers as a very unusual form of what we call DNA mutations, called microsatellite instability. These types of colorectal cancers, and there's some endometrial and ovarian cancers like this, have thousands, maybe tens of thousands of mutations in their cancer cells because they don't have what we call mismatch repair genes. And the hypothesis was very simple. Well, these things have tons of mutations, so we're going to roll trials in an immunotherapy trial and see whether or not there's a much higher response to these immune checkpoint inhibitor therapies. And the results were night and day. There were patients that we now kind of colloquially call having Lazarus-like responses, patients who were about ready to go to hospice, patients who had burned through every single chemotherapy and then some in clinical trials, and they got on this trial and they're walking around and they're okay. And this has led to really the first FDA approval of a cancer drug that we call tissue agnostic. It's not for any given type of cancer, it's for the genetics. And they have to be what we call microsatellite unstable or show microsatellite instability. So getting back to the spliceosome mutations, what does that mean? Well, I think if you recall, I showed you that these things are creating new proteins, not at the DNA level, because the DNA, remember, is the same. The RNA, because of the mutant spliceosome, is now creating lots and lots of new proteins and lots of mutant RNA molecules, if you will. So we did kind of the same thing. We looked at the early first 5 trials where there were sequencing data on immune checkpoint inhibitor therapies. And again, these are not very common, so there's about 250 patients across those 5 trials that had sequencing data. 4 of them actually had one of these hotspot mutations in the spliceosome genes, and they all had a response, including one durable one. Now, it's an N of 4. You can't really make much of that, but even if you do statistics on 4 versus all the other patients and the expected responses, that's still highly statistically significant. We also have a molecular tumor board that I started a number of years ago, and we actually came across a lung cancer case. This was a type of lung cancer that can get these immune checkpoint inhibitor therapy since it's approved for it, but this patient did not have a high tumor mutation burden, but did have a mutation in SF3B1 and actually had a very good response to these therapies. So that really got us thinking, wow, maybe we could do this in a trial, but how are we going to get all these patients? So our answer to this is what I'm calling a virtual trial of immune checkpoint inhibitors. And so this is an idea borrowed off of 2 concepts, which I'm going to get into in the next 2 slides. But we're going to initiate this from Hopkins. We're going to involve patients, hopefully you all as well, to get the word out that if you have a breast cancer, a metastatic disease, and you've had sequencing of any type, Foundation Medicine, your hospital, as long as it's what we call CLIA grade so that you can act upon it, we want to see that. We're going to register you online. We'll have a consent form online, and we're going to examine the actual gene report and see whether or not, one, is there anything that's really actionable by today's conventional standards? Would other therapies be more appropriate? That's kind of what the tumor board does. But if not, then enroll in our trial of using an immune checkpoint inhibitor, of which now there are 2 that are, actually 3 or 4 now, that are actually FDA approved in other types of cancers. So these would be fairly easy to get what we call off-label use. And I think that that's something that, again, is a little bit out there and different, because it's not going to be patients having to come here getting the therapies at Hopkins. We're going to work with the local oncologists and the patients directly to see whether or not we can test this hypothesis, again, patient by patient. The other thing we're going to do, and Robin had mentioned liquid biopsy is an area of interest and expertise of our lab. We're going to actually request blood draws. We can get mobile phlebotomy. Robin taught us and piloted that with us. And so we can actually get what we call cell-free DNA and confirm the mutations. We're also going to look to see if we can track progress using the quantitative aspects of what we call liquid biopsy. So when you get a liquid biopsy, it tells us not only what are the mutations in a patient's cancer that is now floating in the bloodstream, it'll also tell us how much. And so if we can use that to say if it's going from here to here, and that's correlating with good response, that's another end point of this particular trial. But this is something that, again, draws from 2 prior concepts that were not started at Hopkins, but by colleagues. The first is the Metastatic Breast Cancer Project, and again, I have to thank Robin to bring this to my attention, because I didn't know about this. This went directly to patients, and Robin was the first one to tell me, hey, have you heard about this thing? So colleagues at Dana-Farber, a guy named Nicky Wagel now has really spearheaded this when he was a trainee there and is now a faculty. They just wanted to see if they could reach out to the metastatic breast cancer community and enroll patients, and also ask for consent to get tissues, cheek swabs later, et cetera. But it was really initially just a proof of principle. How many patients can we reach? And I think you can see the inflection point here once it gets on Facebook and Twitter. Really powerful stuff, as Donald Trump knows. We can really start to increase the inflection of that particular enrollment. So the astounding thing is in 8 months, they had enrolled over 2,000 patients in all 50 states. So that really actually gave us a lot of hope that we can use social media for good and the power of patients as advocates. TAPER is also a very interesting trial. This is the American Society of Clinical Oncology, or ASCO's first clinical trial. They're not really in the business of doing trials, but this was an opportunity that I thought was really inspired. Many people have probably heard of the NCI MATCH trial, where patients get their tumor sequence and then they can get on drugs. But these are usually experimental drugs, not always, and it has to be done, the sequencing has to be done at one of several centers specifically. TAPER took a very much opposite but parallel pragmatic approach, where they said, we'll take anyone's sequencing data, as long as it was, again, done in an approved lab, which most labs are nowadays. And then we'll have our own tumor board, and we'll see, and they've partnered with drug companies, if there's a match. But the match is really for FDA-approved drugs for cancers other than the one the patient has at that particular instance. And so this has really taken off, and many centers are now a part of this. They've also partnered with local community oncologists, because this has been a huge problem in our business. Probably only 5% of patients in this country actually ever enroll on a clinical trial or have the opportunity to get on a clinical trial. This is trying to do some outreach so that we can actually get more patients involved. And so our clever acronym, I didn't come up with this, my fellow did, Patient Response to Immunotherapy Using the Spliceosome as a Mutational Marker, or PRISM. Again, the idea is online recruitment, try to get a lot of patients screened to find those patients with rare mutations. We're also, I should say, partnering with Foundation Medicine. They're one of the big sequencing center, or sequencing companies, I should say, for tumor sequencing. But they have told me that they will also put, once our trials register in clinicaltrials.gov, they'll put that and match it with any SF3B1 or spliceosome gene mutation that they find in the reports. I think that's also going to really enhance and help our recruitment efforts. Our current progress, we do have a website that's up. It's not live in the sense that we have the consent forms and everything going on, because we're still awaiting our IRB approval. But the website's been created. I think it's not accessible from the outside, but only through our intranet. But when it opens, again, check our Twitter and Facebook feeds, and you'll be the first to know. So in conclusions, hopefully I've convinced people here that targeting spliceosome mutations really represents a potential novel immunotherapy target. But again, I think the bigger picture of this is that this is going to be hopefully a positive proof of principle. I think to really move the needle forward, we have to do a lot of trials like this in parallel to really figure out, hey, for every patient's breast cancer, what is the underlying genetic insult that's making it tick, and can we get better drugs for that? I think if we really start to exploit that angle, we're going to cure a lot more breast cancer patients, and my hope is that includes the metastatic patients as well, because this is something I do firmly believe in. And again, I've given you examples that there are a number of patients right now that I think have metastatic or had metastatic disease and no longer do. I think with that, my 20 minutes are up, and I do have to thank a number of people in the lab, particularly Tasha Hunter is a fellow in the lab who's started all the immunotherapy PRISM trial. Brian Dalton was an MD PhD fellow in the lab who's now joined faculty, but he really led the whole charge of doing the basic science in the lab that led to the translation, and then all the other wonderful people in my lab, clinical collaborators both at Hopkins and beyond, and of course, funding sources, and especially Susan G. Komen. And with that, I will be happy to, well, am I taking questions now or just waiting for the answer? Okay, I'm happy to take questions. Thank you.
Question over here.
So are you saying that there's something beyond NED? No evidence of disease and no evidence of active disease for stage 4 metastatic patients?
I am saying that. I don't have proof of that. That's the hard part. But I do think that there are living examples where patients off all therapies who have not recurred for a number of years.
What is the number of years?
Well, I don't know if I can share information, but I do know of some patients who have been off for probably about 5 years or more and have not had any recurrence of their metastatic disease. So it is remarkable. The last time I was talking at, I don't know if it was the Komen event or a local one for Hopkins, patient came up to me and she said, almost embarrassingly, Dr. Park, I didn't want to say this in front of everyone because I think it'll make people feel bad, but I got cisplatin as a single agent drug with metastatic triple negative disease, and that was 7 years ago. I've not had any therapy since, and it's never come back.
Yeah, I imagine that does happen, but we're still losing 40,000
absolutely.
people a year to metastatic disease.
Absolutely, and so this is what I'm saying. We have a long way to go, but I don't think
in the United States.
Yeah, exactly. We don't have the, there's no magic bullet that's going to cure all breast cancers. And so the idea in the old days, I think, of let's try to get something that will get at least 25% of breast cancers. We did that with HER2, but beyond that, I don't think that all the low-hanging fruit has been picked, so to speak. I think right now we have to learn from what we've done in lung cancer and other cancers that rare mutations are still worth going after and can have dramatic results. And so I think the examples here that I showed with the juvenile secretory breast carcinoma, and I'm hopeful with this immunotherapy trial will really speak to that. But this is something where I do think we have an opportunity, and I would almost say an obligation, to really look into this and really figure out whether we can cure more patients.
I don't know why I ran away.
By the way, I do like to say, as an oncologist, you have to look at the glass 5% full, not 95% empty. And so for me, I think low mutation rates shouldn't matter. We need to really still go after this.
Hi, so my question concerns drug resistance. As someone who is estrogen receptor positive and has now like on 5th line of treatment, I guess when I consider HER2 positive, and you were talking about people doing very well to the point where they can discontinue Herceptin, I guess if there's a way to simplify or simply explain that, why is drug resistance set in for some subtypes and yet not for HER2 positive?
Well, it does happen in HER2 positive, but it seems that there are some HER2 positive breast cancers, for whatever reason, are less prone to developing resistance. And again, I think that really speaks to what I was saying earlier, that every patient's breast cancer is a little bit different. When we've sequenced patients in the past, we know that there are some common mutations, a gene that our lab had worked on a lot, called PIK3CA that may mediate some resistance in some studies to HER2-directed therapies and not in others. But I think the situation's a little bit more complicated because what we're learning now, part of the reason why drug resistance develops is that there's this inherent genetic instability of cancers. When our normal cells divide, the DNA is exactly the same. They have to be. And there are repair mechanisms that ensure that. So without 100% fidelity, that's where cancer starts. When you start having a mutation here, a mutation there, the race has begun, so to speak. And then there's some sort of genetic instability driving that process. When we have metastatic disease that we can clinically or radiographically detect, usually we say it's got to be about 1 centimeter. That's already 1 billion cancer cells. And each one of those cells is a little bit different. And that's why we can kind of get rid of most of it, sometimes seemingly all of it. But all it takes is one errant cell left behind that will eventually grow. And as it's growing, it's going to evolve and generate more kind of progeny, if you will. So the problem that we're dealing with is much more complex than originally thought. There's a newer kind of wrinkle in this, what we call tumor heterogeneity, that it's not even probably one cancer cell in many patients. It could be that there were 2 or 3 clones, as we call it, from the beginning, and they're working in cooperation to actually live as a unit. And striking down one of them may not actually afford the ability to hurt the other two, and vice versa. So again, there's a lot of work that still needs to be done, and this is exactly right why 40,000 women a year are still dying from metastatic breast cancer. But again, I think there is hope, and I think that there's always an opportunity to do more.
Hi there. This has been really interesting for me. I'm a couple years in, and you listed 5 different things, and maybe this is really obvious to everybody except me. Is there some cost for people to submit their information? And again, I'm a couple of years in, but this is the first I'm hearing about all of these things, and I'd be curious if you have any insight for folks as to how people can get more information sooner. And then my sort of second part there is someone initially did mention to me CRISPR, and they said, yeah, you know, you should get involved. It'll cost you about $175,000. And, you know, obviously I said, well, that's fascinating. But so I'm curious if that's sort of inherent in these 5, or if there's a different approach.
So CRISPR really is still a laboratory technique. There are a lot of centers and countries outside the US who are experimenting right now using it as a gene therapy approach or even a genetics modification approach. Here in the United States, that's much more tightly regulated, and so that's still kind of science fiction rather than fact at this point. Certainly in the lab, this has become a huge tool, and it'll probably win, you know, the Nobel. Maybe it did already, I don't remember, but this is something that has been exciting for the biomedical research community for a few years now and is slowly starting to make its way into the clinics. But the other aspect of sequencing and then sending information, sequencing historically for breast cancer has not been a standard of care. And so because of that, many insurance companies wouldn't pay for that. Now, that said, a lot of the commercial entities would just eat the cost anyways, because there are some cancers, like lung cancer, melanoma, where we really have bona fide target or drugs for bona fide targets. And again, that's going to evolve with breast and other cancers as we move forward. There's been some interesting politics and dynamics in terms of sequencing of tumors recently. The one company I mentioned, Foundation Medicine, who's kind of the granddaddy of all these companies, as well as Memorial Sloan Kettering, got FDA approval for their test, and now that is going to be covered by insurance. There's some backlash right now because that probably means that all the companies that are, and institutes that are not FDA approved, it won't get covered. So there's still a seesawing back and forth of who's going to pay for this, how, et cetera. But getting to your other point, the Metastatic Breast Cancer Project as well as ours, there's no cost involved other than the cost of it might take for your internet to, you know, scan a document and send it over a secured server. And then we will actually bear the cost in the trial of actually doing the analysis of the data and seeing whether or not it would make sense. Did you have other questions? I'm sorry. Okay.
You just brought up something I was going to raise, and that is that sequencing of tumors is not yet a standard of care in the clinic. So this all sounds exciting. I think people who have metastatic disease in the room would like to know if they have a high genetic mutation burden or
Yep.
load. So what are we to do when we're working with our oncologist who may not be as smart as you, no offense, or may not be working in research? I guess that's one issue. Do we need to go to a comprehensive cancer center? And then the second part of my question is, what can advocates do to make genetic sequencing a norm?
That's two great questions. For your first, I would tell you, one, I'm not smart. I just fool a lot of people into thinking that, but thank you. The first, I'm a big believer of second opinion. As Robin knows, that's pretty much all I do. And I am more than happy to see patients for second opinions to discuss these issues. In my own practice, once a patient gets a metastatic biopsy, that's almost become standard of care because we want to recheck receptor status. Sometimes that can change, and sometimes that actually changes our therapeutic options. And so if you're going to do that anyways, it's usually trivial to get another core or even use the same sample if it's adequate enough. And so I actually make the argument that at some point down the road, when we're talking about, I don't ever recommend this for early stage disease because the last thing you want to do is muck with standard of care that's been known to help cure breast cancer. On the other hand, in metastatic breast cancer patients, as we've all been discussing, the majority of women are not going to have a cure as their end goal. So at some point when therapies stop working, or maybe even a couple of therapies before that, I would like to know what's going on in that patient's tumor. We have had some remarkable responses, and we have had some trials and therapies that have really made dramatic impact on patients' lives. I'll give you an example. Most of the times when we think of HER2 positive disease, that means that the normal DNA copy of HER2, the gene HER2, is amplified. That means the normal gene is copied again and again and again and again in an aberrant fashion. That's what HER2 amplification really is. It turns out in breast and some other cancers, there are what we call mutations. So they actually changes the letter of the alphabet. So they're not amplified. And there are some ER-positive breast cancers, lobular subtypes. There are some triple-negative breast cancers that turn out have these mutations. And now we have drugs, HER2-directed therapies, neratinib, Herceptin, Perjeta. They all seem in some cases to have an effect. And I've actually personally seen this. So I actually started our molecular tumor board 4 or 5 years ago because I was a skeptic. We're taught in academic medicine, high-level evidence, et cetera, but with these rare mutation types, we won't ever be able to truly get that level of evidence because they're just not that common. So we have to go with what we know and what we can test. And as I've seen these types of responses, I can't put my head in the sand and just say, well, it's just an N of 1 or an N of 2. It reminds me of that story of the little boy and the starfish, where there's thousands of starfish on the beach, and he keeps throwing one back in, and someone said, you're crazy, you're not going to make a difference. And he said, I did to that starfish. I think that's really true. It's really hard to ignore that type of response. It's hard to ignore patients who want to know what's going on with their tumor if there's a drug or a therapeutic trial or option for them. So I really have evolved my thinking about this over the years, and I've seen some really miraculous responses. And that's why I'm an advocate for it now. I'm not totally off the deep end saying every patient should get this done. But I do think if you're having problems with a physician who doesn't believe in this or doesn't want to do it, seeing a second opinion is always a good thing. Seeing an academic medical center that actually has access and resources to help along, I think that's a really good thing. And then to your second point, I think patients need to also get the story out. And not in a way that I think discredits anyone's, stance on this, but in a way that says there are going to be instances where if we don't find anything, at least we can have that information so that when a trial opens up for a particular mutation, and if you happen to have that mutation, we can call you back and say, hey, we got something for you right now. Would you like to join?
I think we have one last question.
Okay.
First of all, Doctor, thank you so much
You're welcome.
for your
Thank you.
dedication to helping us all. And your presentation was terrific.
Thank you.
My question is very focused about a woman I met a week ago. We were at a conference in southern Florida on complementary and alternative treatments for metastatic cancers. I met a retired nurse who's been living with metastatic cancer for a number of years. She asked me if I had ever heard about the blood test that she had. She sent a blood sample to Greece. She even said it ran 2,500. She said the sample would give her the best treatments in terms of chemotherapy that would attack her cancer. And in addition to that, the test would also give her the best supplementations that she should take that would help her in fighting. No one uses the word curing, but in stabilizing the cancer. I'm wondering if you could address that blood test and if we have it here in the U.S.
Yeah, you could probably order it from the U.S., and there are a number of other companies that are selling similar types of tests. I would tell you those are the tests to really be wary of. I've seen patients in second opinion clinics who have come with those results, and I've researched on them. One, I look at this and I've never heard of this before, and then I research them, and there's absolutely no data behind it. So it runs the gamut. You know, again, one of the reasons I started Molecular Tumor Board is because I was worried these companies were kind of selling stuff. And I think some are, but I also think the good ones really understand that they have to work hand in hand with people who are doing the research, people who are actually physicians and scientists to bring it forward. I haven't found companies that you're describing to really do that. They're very close off. They don't want to discuss it, and that right away raises my level of suspicion. On the other hand, complementary alternative medicine, I think, is an unexplored and potentially very important field. And more academic medical centers, including ours, are really starting to do trials on this. For those who may have heard of the whole mistletoe thing, you know, there are anecdotes everywhere, but nobody's really put that mistletoe into a real clinical test. And so someone at Hopkins, one of my colleagues, started doing this for both prostate and breast cancers. And hopefully we'll get some answer behind this. But I've been told by patients that, yeah, I did this, or I know of someone who did this, and they seem to have a response. So there could be something in there that we just don't know about it. And I think there are real examples where, you know, patients telling us about certain things can really lead to benefit. On the other hand, I always worry a little bit too. When I was training in the 1990s, there was a substance called black cohosh. Maybe some of you have heard this, that everyone said, oh, this is it for ER-positive breast cancer. And then it turns out it's actually more of an estrogen than anything else, which, as you can appreciate, is the last thing you want to take if you're an ER-positive breast cancer patient. So one has to be very cautious, and I would ask everyone, if you're thinking about things like that, please do talk to your physician about it or get a second opinion. I also don't think it's helpful for physicians or healthcare professionals to just poo-poo this and dismiss it, because I do think that there are, in fact, some real pearls and nuggets of knowledge that could come from this. Thank you very much.
Thank you. So now it's time for our breakout sessions, and it's about a 5-minute break. So again, it's by color codes, and if you self-identified as one of these subtypes, you can see your color-coded dot on your name tag, and just making a note that Dr. Rita Nanda's room is going to be room D. You'll see the signage. They're all in the hallway where you see the big squares out front. And then if you did not self-identify as one of the three, feel free to just go into whatever room that you're most interested in. And Dr. Ben Hope Park will be in this room hanging out, and he'll have a Q&A at the end of his session as well if you're interested. So feel free to go to your breakout sessions, and they will start promptly at 3 o'clock. Awesome.
Yes.
If you need a little entertainment while hanging out in here, I have a little video to show you.
Hi. That's a very nice. Oh, thanks. Are you ever heard the Okay. So we're trying to meet them too. Do you know where's Yappy at all? He's a big immunotherapist for GI. Yeah. Good shot.
Michelle and I met, we were together for 16 years. Once we met, we hit it off, and we were inseparable ever since. And then in 2013, that's when she was diagnosed with breast cancer. She went into her treatment February and had passed away May 11th. Yeah, very quickly. It was really just a quick downslide.
When I was diagnosed with cancer, I was 6 weeks in to my residency. 6 weeks into my new employment, 6 weeks into my benefits and my insurance. When the cancer diagnosis came at that 6-week point, I was not eligible for anything. Not short-term disability, not long-term disability. In fact, beyond taking all my sick days and my vacation days, technically, I was not eligible to keep my insurance if I couldn't work.
Some of the tangibles are, barriers associated with finances. A lot of times, the women in our communities have to make decisions between purchasing groceries and paying their copay, and that should not be a choice that any woman should make.
I am Judy Gittelman. I'm the Executive Director and founder of ALAS Wings. ALAS is a not-for-profit organization that helps Latino women going through breast cancer treatment. Without our help and without the Susan G. Komen help, we'll not be able to afford, in this case, buying products or going to or doing presentations or learning more about what breast cancer is.
We always got along with each other, and we always share our feelings, and we always support one another.
When I got diagnosed with breast cancer, she was there for me too. It was just a little shock for me. When I told her, she says, everything will be fine, right?
Yes.
The procedure that I went through, it was just like, if I don't do it right away, you're gonna die. And that's miscommunication.
I remember very clearly going through treatment, and I met women that didn't understand the language, couldn't speak to nurses. I realized that I needed to help other women that couldn't understand what was going on and what kind of treatment they needed to do.
This group will tell you exactly you need to open up. It's not only you, it's a lot of women who goes through this. We need to help each other.
Because all women need that support. We need each other. That's the most important part.
So Robin came to see me as a second opinion about probably 7 or 8 years ago now. But she had already been diagnosed with metastatic stage 4 breast cancer.
I asked him my 2 questions. How long do I stay on the medicine, and what about surgery? And he said, I don't know.
And at the time, we're talking again 7 or 8 years ago, the answers were, I don't know and I don't know.
And then he said, well, there have been about 10 biased, not such good studies done, but they all point to saving lives, to extending your life with having surgery. And I was like, okay, that's the information that I needed to hear. So then I went ahead and had surgery here in Chicago. So he has a real small sample of my biopsy, and he told me it sat on his desk for a number of years.
Until the technology matured, and unfortunately that was actually this year. So for the very first time, we now have some findings on her tumor.
So then he's like, all right, let's keep digging at this.
And so if we chip away at this, the hope is that by the next 10 years, as the laudable goal of Komen is, that we're really going to affect mortality from this disease.
My name is Jessica Jones. I have 3 kids, a stepdaughter, and 2 crazy boys. I look totally normal, but I feel like a 90-year-old inside. So it's strange. People are like, man, you look great. Thank you. I go, at least I got that going for me, because I don't feel that way inside. Susan G. Komen has helped me a great deal in providing the emotional support and a purpose to why I may be in the fight that I am in. Metastatic cancer is a separate beast. I mean, it's a beast. So, sorry. If I can be helpful to somebody, I want to be that person.
You want to grab everybody, you want to love everybody, and you want to stay united together as a group, working together. How can we get past this?
We talk about it, but we do not really practice it. We need support, and we need a plan to truly connect all the pieces from the very beginning all the way through longevity and quality of life.
Yeah, it is important to me because I do donate money, and I get friends and family to donate money to breast cancer. I do feel like Susan G. Komen is a great place to put your money for breast cancer.
Well, you know, cancer sucked, right? But at least I got to. At least I got to be here.
And that's what inspires me to help give hope to patients. I feel like there's a lot that that has been done, but a lot that we can still do.
I fight for everyone in Chicago to have high quality health care.
I fight for underserved Latina women.
I fight for unlocking cures.
I fight for a long future.
Okay, so we're going to start, and Dr. Park wanted to do this a little bit more informal, as more of a question and answer versus having slides. And what's very funny is I was just telling those guys that I remember emailing you about the Metastatic Breast Cancer Project. I remember reading about it, and I had no idea that was the first that I told you about that. So you learn new things every day. So do you want to start?
Yep.
Then?
So, welcome. This is the ER positive metastatic breakout session. I can talk a little bit more beyond that if you would like to. When I've done stuff like this in the past, what I found most helpful is that patients or family members or whoever's in the audience just ask a question, and then I'll try to expand from there. And usually I think that will fill the space up. How much time do we have, Robin?
I think 20 minutes.
Oh, might not even be enough time.
Let me go find out.
Okay. So does anyone want to start? Yes. Sure. Could you use the microphone? I don't know if that's on or not. There's one right in the middle there, I think. Oh, I guess it's not working.
So when you talk about metastatic disease, can you say what sites the breast cancer metastasizes to most frequently? And also, what is your relationship with like a neuro-oncologist at Hopkins to address some of the cognitive deficits that may occur once it metastasizes to the brain?
It's a great question. So the most common sites that breast cancer tend to metastasize to are the bone, and the bones usually are things what we call the exoskeleton, so things like the collarbone, the spine, and the ribs. Tend not to be as much in the long bones, but can really go anywhere. The lungs, the liver, and then also the brain, as you were pointing out. Now, breast cancer can really go anywhere. And there are certain subtypes, I had mentioned lobular carcinoma before, that can really go anywhere. And so many times if a patient who has had lobular breast carcinoma develops stomach pains or something like that, and we see a mass, that to me is usually metastatic disease until proven otherwise, because lobular breast cancers can go to the GI and or GU tract, so the ovaries, the uterus, etc. But really breast cancer can go anywhere. The second part of your talk is, I think it is very essential to have a good, close working relationship with neurosurgeons, and particularly at Hopkins, where our neurosurgeons are usually super subspecialized into being neurosurgeons who deal specifically with either primary brain cancers or metastases from other sites. And so they really are kind of the world's experts and technical experts at evaluating who would be most appropriate for having a brain resection or a metastatic lesion resected from the brain, as well as who is not. And I think that's a very important distinction. And then also to add upon that, also follow up with the neuroradiation oncologists. These are the people who give radiation therapy. And so usually there is some form of radiation therapy that's followed after brain metastasis. This is something that's relatively new, I will tell you. When I was training in the 1990s, that was unheard of. Neurosurgeons would never go after a brain lesion. So studies have really supported that this is probably a better outcome in terms of a number of things, longevity, but also even cognitive function, as you were getting at. And so I think that the appreciation that radiation does a lot more to normal brain cells than we once thought it did has led to a kind of a paradigm shift where we're now actually doing surgery as a field much more readily than just doing radiation. And now we can kind of do very specific spot radiation, if you will. Despite what I just told you, sometimes whole brain radiation has to occur. And yeah, there are some programs to try to address cognitive deficits, but I'm not aware of any that are so effective that we can say, oh, you should always get radiation over surgery at this point. This is a good question. Yes?
Hi, there was a brief mention of complementary therapies and supplements in the last group. And my question is, are there any complementary therapies that you recommend to patients?
You know, I don't, because I'm always a little bit concerned. It depends on what the complementary things that come to me are first and if I've heard of them or not. But I'm always a little bit worried about the ones that I don't know about, whether they're actually going to interfere with any standard of care therapies and potentially either make the side effects worse or make the drug not work as well because of interactions. And so this is what I'm always kind of preaching, is that there are a lot of powerful complementary alternative substances out there. Most people don't recognize, but all the taxanes, Taxol was actually derived from the Pacific yew tree. So one of our best chemotherapies from breast cancer, I would consider, was from kind of a complementary natural substance, as was a relatively newer drug called eribulin, which is from a sea sponge. So I'm a big believer that there are really active substances in things that patients can find over the GNC store, but what I'm not sure of and where I'm cautious is it going to cause more harm than good? Is it going to cause any good? But again, for me, it's the harm part that I'm also worried about. So for me, the things that get closest, that I can scientifically recommend that get closest to complementary alternative medicine, is really healthy living. So a good diet. I don't think you have to go completely, one way and say, I'm not going to eat a certain substance, et cetera, et cetera. But yeah, healthy diet, exercise, these are things that have actually really been proven to make a difference in terms of survival and keeping an ideal body weight. And the other aspect now is that I keep touting is the mental well-being and health aspect. Rob and I were just talking about this. There are some really older studies where the difference in longevity as well as quality of life is hugely affected by seeking professional help, by actually not being depressed. I think that these are really tough challenges, particularly for metastatic patients, but also even for early stage patients, because after all their therapies, they're worried about, hey, is this going to come back or is this not going to come back? Am I cured? Am I not cured? I think that is an area of unmet need that we really have not addressed adequately in our field. And so I've been referring a lot more nowadays and really trying to counsel patients that, living in fear is not really living, and depression really can shorten lifespans. And so I would encourage everyone in this room, if you hadn't thought about mental well-being, to really give that some thought, and if you really do need help, to go and seek it. Thank you. Yes, sir.
So
Mhm.
Could you say a little bit more about that? Because
Sure.
I think you implied that it has the ability to metastasize to areas that maybe the different other kinds of cancer don't.
Correct. So lobular breast carcinoma is the second most common type of breast cancer in this country, but it's still a distant second. So most of the breast is composed of ducts and lobules. Lobules are where milk is made, and then they actually go connect to the ducts where milk is extruded out through the nipple. Lining those structures are cells, human breast cells, and those are what become cancer. So if they're in the duct, that's what we call invasive ductal, or if they originate from the duct, that's what we call invasive ductal carcinoma. Some of you probably have also heard an entity called DCIS, or ductal carcinoma in situ. Those are cancer cells that are still in the duct. It's a little bit of a misnomer because cancer is not really cancer until it invades outside the normal architecture, in this case the ducts. And so that's why we call ductal carcinoma in situ, or DCIS, stage 0 breast cancer. It kind of doesn't make any sense for a lot of people, including myself. That's about 80% of breast cancers. The cells that are in the lobules that turn into cancer are invasive lobular carcinoma, and that's about 10%. And so the two together make up 90%, and then strange types outside the ducts and lobules collectively make the rest of the 10%. Lobular breast cancer is actually hallmarked by a well-characterized molecular change. It's a mutation in a gene called CDH1, and that encodes for a protein called E-cadherin. Why is this important? Well, E-cadherin is a sticky molecule on the outside of a cell. And when you lose that, you actually have a greater propensity to slip and go through blood vessels and lymphatics. And therefore, lobular breast carcinoma tends to be a little bit more invasive in terms of metastatic potential. And yet we think it has a slightly better prognosis, at least short term, because it's almost always estrogen receptor positive and usually very sensitive to endocrine therapies or hormone therapies. And so with the advent of things like tamoxifen, aromatase inhibitors, now we have in the metastatic setting fulvestrant, palbociclib, ribociclib, abemaciclib, et cetera. This has really started to change the natural history of metastatic breast cancers, lobular and ductal. But again, lobular probably more proportionally so, since the vast majority of lobular breast cancers are estrogen receptor positive. It's also important to note that if you ever hear of any young patient, or maybe not even that young, who has lobular breast cancer along with a family history of stomach cancers, that's a group of patients or a family that should be referred to genetic counseling, because that same gene that I told you about, CDH1 or E-cadherin, that can also be mutated in what we call germline. Germline is the thing that we also get tested for BRCA1 and BRCA2. It's heritable. And so the same gene that's mutated in sporadic or normal lobular breast carcinomas can be mutated in every single cell of the body, and therefore it can get passed along to kids. It's inherited from either mom or dad. And you can get families that have lobular carcinomas, but they also get gastric carcinomas, because that's also the etiology, if you will, of the pathogenesis of those gastric carcinomas in that family. So if you do have lobular breast cancer, you know someone who does, but they also have a family history of gastric cancer, those patients should be referred to genetic counseling for testing. Great questions.
Hi. If my oncologist says that he doesn't see a point in sequencing, would I have an option to go to a private lab and have it done myself? And if so...
You do, always, as a patient, of course you do, but I'm not sure that would be your best avenue versus finding someone who would be your advocate. I would be happy to be that if you needed it.
Okay.
Because I think you want someone not only to help with the process of ordering it from wherever the path lab is, et cetera, and filling out the forms that really, physicians have to put their certain numbers down, et cetera. But I think equally important is when you get those results back to make sure that, and it's oftentimes not community physicians, although it's starting to grow, but to make sure that someone who has expertise in this business can interpret this. The companies will actually write things down that are only maybe half true. And so I think that that's the danger of a lot of these reports, is that you get these annotations, and again, these are in some cases now colleagues and friends of mine, but they don't have clinical training and background and the genetics background. They usually have one or the other, and they'll put things down like a certain gene mutation predicts for response to everolimus, which is a drug approved for breast cancer, and it's not true. It's actually been now shown been shown not to be true. Before we'd say maybe, but now we actually have evidence it's not even true. Yet those things are still on there. So for me, a big part of my mission over the last 4 or 5 years has been to try to educate not only patients, but physicians as well, to understand what these reports are, what they mean, what they don't mean, what's tested, what's not tested. That's becoming equally important right now. And so I would encourage you to get this done if you really think that you want to get it done, but also in the context of someone who knows what they're doing.
Yeah, I definitely want to take part in the PRISM trial. So who would I go to?
You can email me.
Okay.
I'm easily findable on the web.
All right, great.
I did not design our webpage, though. It's very sophomoric, so that was done by one of my trainees. I do support it, but I don't design it.
Thank you very much.
Another question about sequencing. Are there certain tissues, or is bone as good as
that's a great question.
And also, like pleural fluid, is that good?
So the short answer is yes. The long answer is it depends. So for pleural fluid, for example, what we're really sequencing are the cells that can be there and often are, but not always. There's not always enough cells. So the lab will, once they take off the fluid, whether it's pleural or ascites, they can spin it down. And if there's enough cells, then there's enough DNA and they can do it, but that's not always the case. Similarly with bone biopsies or bony lesions, because of the process of demineralization that the pathologists have to do all their normal testing, that can sometimes hurt the integrity of the DNA, and so it's not always possible to get good sequence data from a bone biopsy. So the usual places that people with breast cancer get is usually the liver, because that's fairly accessible. It's usually a very safe and easy procedure to do, assuming that it's superficial enough to the skin, and that's usually more than enough to do the sequencing. Again, there's a lot of usually in there, but I think that the other alternative is this area what Robin had talked about, that we've actually worked with companies on, called liquid biopsy. So it turns out all of our cells secrete naked, free-floating DNA into the bloodstream. And nobody really knows what this is. We've known that it's existed for about 4 decades, believe it or not, but we didn't have technologies until recently to actually do something about it. So they're just these short little fragments of DNA. They don't last in the body very long. They get excreted. I actually call it cellular poop because I think they're just waste products of the cells. But we can now capture those and sequence that. The problem with that is that it's the proverbial needle in a haystack. Most of the DNA floating around in the blood, we call it cell-free DNA, is from our normal cells. And so the tumor, even with metastatic disease, is underrepresented in the blood in terms of the amount. And that makes it challenging. So we're not at the same level of sensitivity using liquid biopsies as we are with tissue biopsies yet. That will probably change over the next 5 to 10 years. The potential advantage, however, is that when we biopsy a single metastatic site, that is all we're getting. And so it can be prone to sampling error. And so even though you may have ER-positive disease here, it may actually be ER-negative elsewhere and vice versa. And you may miss a mutation because it's only in this liver met but not in the lung met. And we and others have proven this, that in metastatic patients where we do a liquid biopsy, the blood is acting like a reservoir for all the sites of metastatic disease. So you really actually can get more information that way. But for right now, tissue biopsy is still the gold standard. Again, I just want to reemphasize, whether you get a liquid biopsy or a tissue biopsy, this is not standard of care, and you have to be careful who interprets this. All right, so I would encourage you, if you do decide to do this and talk to your physician, your care providers about it, to also make sure there's someone at the back end who's going to be able to help you interpret this.
So I'm adopted, and as a result of being adopted, I had no genetic history. So there was a full panel of genetic testing that was done to determine if this was a genetic cancer, because I have daughters. Is that the same as the genetic sequencing, or is that totally different?
It's not totally different, but it is different. When we're talking about testing that you did, and I don't know how many genes you had done, 10, 19, that's what we call germline. So that's like BRCA1, BRCA2, and now up to 30 genes can get tested. The danger with germline testing is that we're looking after the most common genes that we know of. There's about 25,000 genes in the human genome, and we're testing 30 right now, because that's all we really know that can be associated with. And we're being very cautious about who gets tested for a number of reasons. But I think for that type of testing, what we're really looking for is, do you have something that predisposed to breast cancer or other cancers? And if you do, it's potentially, as you said, heritable, so that you could pass it down to your kids. We all get half our DNA from mom and half from dad, and so we can give half our DNA to our kids. So if you had something, then your kids would have a 50-50 chance of inheriting it. Now, up until a few years ago, I would tell you that has no bearing therapeutically. What we're doing in tumor sequencing is we're actually taking the tumor and then sequencing all the mistakes in that. The majority of mistakes or mutations that we find are going to be just in the tumor itself. That's what we call a somatic mutation. But because these are derived from normal cells, if you had BRCA1 or BRCA2, that's going to show up. And so the companies don't tell you whether, because they can't for sure, whether that's actually germline, something you can pass along and inherited, or is it somatic, just in your tumor. So some companies now and some institutions are doing both. And then they will filter out and subtract out everything that is germline, and you just get what's in the tumor. Now, the big disadvantage of that is you lose the potential to say, I found a BRCA1 or BRCA2 mutation. It's all done electronically. Tumor testing doesn't require a lengthy patient consent like you had to go through for your testing. And so that's created challenges. And I've talked to some companies, and now they're actually not filtering out BRCA1, BRCA2, and some other genes that have therapeutic implications now. So the two are starting to merge, but this is also what I mean. I will bet you most oncologists don't know the difference, because this isn't something we're trained in medical school. When I was in medical school, it didn't even exist, really. And so unless you're talking with someone who does this for a living, I think it's very, very important, what I said earlier, on the tail end of getting these results back, you really want to talk to someone who does this for a living, who has expertise, who knows that what companies are using both germline and tumor testing to filter out what gets filtered out. Do they even get filtered out? Some institutions like Memorial have always been doing germline and somatic and just electronically filtering them, but they now also understand the implications of that. So they are offering genetic counseling and consenting if patients elect to get the results of both their germline and their somatic. So again, lots of terms, very complicated. The short answer is just be careful. Make sure you discuss this with someone who really understands, and if you need some advice on that, shoot me an email and be happy to point you to people in your areas that are kind of the world's experts in this. There's lots of us out there, but per the country, there's probably not that many, but in terms of areas like between Chicago and Northwestern and other centers here, there's plenty.
So right now you're talking about results from these 5 entities that you talked about earlier. Is that what you're talking about having interpreted? I got a little lost.
Sorry. No, I was talking really about any type of testing that requires DNA testing, but especially tumor testing. If you say, hey doc, I want my liver biopsy sent off for tumor testing, someone may actually say, okay, but this company wants a cheek swab. And you'll say, okay, not going to think about why that is. But the reason is because they're doing more than just sequencing the tumor. They're sequencing your normal cells and subtracting them out. And if you've never had BRCA1 or 2 testing or anything like that, that won't show up. These are kind of the subtle, nuances and complexities of where sequencing has gone, and a lot of people are not aware of this. And yeah. Well, and it's really, really important too nowadays, not only from the aspect of, again, saying, hey, my SIBs, who are my blood relatives, my kids, my parents, they could be carriers if I'm a BRCA1 carrier. But then nowadays, and many of you probably know this, we have drugs against tumors that are BRCA1 related, BRCA2 related, and probably, and there are trials going on right now to address this, other genes that are in the same pathway, PALP-B2, ATM, et cetera. So it's more than just saying, hey, I want to know because I want to inform my family members and talk about relative risk. There's also therapeutic implications now. The immunotherapy story I told you about, this micro-instability cancers, those cancers were originally found because there are familial cancer syndromes where those are germline mutations. And so these families will get colon cancers, ovarian cancers, endometrial cancers, and they are peppered with mutations in their cancers. Those are individuals who are perfect candidates for those types of therapies. So again, it's not just the implication of relative risks. Are my kids going to be affected? Are my sibs going to be affected? There are real therapies now, these immune checkpoint inhibitors, if you have one of these types of cancers. They're not that common in breasts, but they do occur. They've been reported, and I've actually seen a patient like that. And I think that this is something where it's all brand new, and a lot of people may or may not be aware of this, both physicians and patients. So again, part of why I want to do stuff like this is to get the word out. I think patients being their own advocates is something that was said time and again here, and I think that's really true. So I'm hopeful that, you know, that message will get across.
Follow-up question. What trials currently exist in immunotherapy for HER2-positive metastatic breast cancer?
There are a number ongoing right now. Most of my work is not in that field, so I can't speak to that, all the different trials. But if one gets on clinicaltrials.gov, that's the website that the government mandates all the clinical trials really have to go through. It's not always that up to date. My colleague who's from the University of Chicago, Rita Nanda, is really one of the world's experts on that and can probably speak more to that. And she's in the, I think she's in the triple negative group right now. That's right. That's right. Breastcancer.org, and a number, and even individual institutions' websites will.
So that's free to use, and it's a search service for metastatic disease. Actually, there's a breast cancer search service too, but there's now been a specific one for metastatic disease that was developed that can be helpful.
Then there were two questions, 1 and 2. By the way, I also want to make a pitch for male breast cancer. I am now part of the Male Breast Cancer Coalition. It's kind of the forgotten stepchild or stepbrother of breast cancer, but I do want to put in a pitch because men can and do get breast cancer, and there's a lot of movement afoot, which is good because heretofore it's been relatively understudied.
Going back to the BRCA1 and BRCA2, 8 years ago I tested negative for BRCA1 and BRCA2, but I understand they are testing further now with more mutations. As I have 2 daughters, should I be tested for those additional mutations?
It's a great question. It depends on who you ask. These guidelines were set in place, and they really are based on odd statistics. But there was a sobering article in the New England Journal of Medicine a couple of years ago by our prostate cancer colleagues where they looked at what they called metastatic castration-resistant prostate cancer. In fact, I think they even used the word lethal. And they decided to test this hypothesis that if you had a heritable defect in a DNA damage repair gene, something like those microsatellite instability tumors, that you might enrich for the population of heritable gene defects like BRCA1, BRCA2, et cetera. And it turned out that was true. So in this group of patients, there was a much higher rate of germline mutations in DNA damage repair genes. This has led us, and I don't know if you're all interested, I feel like I'm advertising way too much here. We have just opened a trial to address this very same question in metastatic breast cancer patients. It's free. If you've had genetic testing of 10 or genes or more, you're probably not going to be eligible. And if it's been positive, you won't be eligible. But if you've only had BRCA1, BRCA2, and maybe a handful of genes, and it was all negative, or if you've never had it done, our only requirement is that a patient has to have metastatic breast cancer. We can actually now do online Skype consenting and mail a kit, and the test will be free. If you're interested, again, look me up on the web. I'm very easy to find. Don't feel shy. I'm hoping my inbox will be flooded. Okay, one there and one there. Sorry. Go ahead.
We have like 2 minutes.
Okay. Sorry.
As far as treatment, initial treatment, I don't know if there's a lot of people in here. I'm 17 months into my Ibrance and letrozole. My oncologist tells me it's not if it will reoccur, but when. What happens when the when comes? What do I do after that?
So that's a great question. The honest answer is I don't know, because it will really depend on what happens when. I do think that it is probably true, based upon all the trials, that Ibrance and hormone therapy is not a cure. At the same time, we are seeing patients with sustained results, patients even beyond 17 months, sometimes years. There have been patients who have actually outlasted the trials, believe it or not. And so we just don't know who's going to have that type of response and who's going to have what we call de novo resistance, meaning no effect at all. I think when you, or if, I'm going to be more optimistic, get to that point, there's going to be a number of options. Our center right now is doing a single institution trial looking at what we call Palbo after Palbo. So patients who have gotten Palbo letrozole first line then switch to Palbo fulvestrant. We don't know whether or not that's going to be an effective strategy, although we've seen some responses, but the rationale behind that are twofold. One, in the old days of Herceptin, where we only had Herceptin for metastatic disease, we would treat with Herceptin and chemo, and so a maneuver when patients got resistant would just to be changing the chemo. So sometimes keeping the targeted therapy as the backbone and just changing the secondary agent can afford a benefit. The second thing is that we know estrogen receptor mutations can lead to resistance to aromatase inhibitor therapies, and even in conjunction with palbociclib. And in some trials, these are all retrospective, but that's what we're also going to look at, using liquid biopsies to see whether or not these mutations can be overcome with Palbo fulvestrant, even after progression on Palbo letrozole. There are also now newer drugs, the so-called Me-Too drugs, ribociclib and abemaciclib, and nobody knows whether or not there's going to be cross-resistance to all classes of drugs. In fact, we've seen patients, and probably many doctors have now at this point, that show response by changing the therapy. And whether it's changing that particular agent, the CDK4/6 inhibitor, or that with the hormone therapy, or just the hormone therapy, we don't really know, because we haven't done a really concerted effort to do the trials like that. But for sure, there will be options to perhaps change therapies to a different CDK or ciclib inhibitor with or without a different hormone therapy. Well, we don't know how important it really is, and I just want to be perfectly clear. That's why it's not standard of care. For me, it's important for an individual if they want to get it done, because if we find something that is potentially druggable, that could afford benefit. The majority of cases, I will be perfectly honest, we don't find things like that. But when we do, it can actually have some remarkable results.
Okay, this is going to be the last question, so you're going to start sending people in. One last question? No? All right.
Hi, doctor. I was just wondering, what is your thought on patients that get directed to taking CBD oils? Once they've been approved to get the medicated marijuana card, with studies about THC and having, the smallest amount of levels, which I think it's like 5 to 10 milligrams a day that you're supposed to take. Do you treat patients that are currently on these oils, or just anything that has to do with cannabis? And
it's a really good question.
Yeah.
The state of Maryland right now, we're still working out exactly how physicians are going to prescribe medical marijuana or oils and the other substances. So I don't know the answer to your questions right now. I have yet to see patients, or at least I have yet to see patients who have told me that they're taking these substances. And I think it's very complicated, because I've heard whispers ranging from the gamut of, it can help side effects to, it actually made my cancer better. So I think it's, again, untapped, or at least unknown, and maybe some potential there. Right now, we in the state of Maryland as physicians don't have prescribing abilities yet.
Okay, thank you.
All right, thank you very much, everyone.
We want to welcome everyone back. Hopefully the breakout sessions were beneficial to everyone. Everyone learned a lot. What we failed to say is today is International Women's Day. So, yes, and I don't know of any more inspiring group of women and men that we have in this room. So just, that is just, it just coincided, so that's just phenomenal. Want to introduce our next speaker. Dr. Lynn McCroy is a fellow of the American College of Surgeons, an experienced breast surgeon who's practiced for 16 years before transitioning to industry. Lynn is the team lead for the breast cancer platform in the U.S. Medical Affairs for Pfizer Oncology. She's held a variety of roles in medical affairs, drug safety, and medical device development while working in the industry for the past 10 years. She has extensive experience in observational study design. She lost me at hello. She just lost me at hello. So smart. Patient-centered outcome research and patient engagement. Please welcome Dr. Lynn McCroy, Senior Director of U.S. Medical Affairs at Pfizer.
Thank you. First of all, I know I can't live up to the introduction, and I am nowhere near as smart as Dr. Benho Park. So, first of all, I'm going to talk a lot slower because I can't even keep track of what I'm going to say as fast as he talks. So, first of all, I'd like to thank you for the opportunity to speak to this audience today. Very much appreciate the engagement and partnership with the Komen Foundation and the efforts that they are making to help educate and help inform regarding metastatic breast cancer. I wanted to just sort of start my remarks by stating that Pfizer has made a commitment to transform the lives of patients with metastatic breast cancer. And the commitment extends beyond the metastatic state to earlier stages of breast cancer as well. However, it really started with a focus in the metastatic state. And one of the things that Pfizer thought was the most important to understand, and this was now back 4.5 years ago, which was actually around the time that I joined Pfizer, they initiated a program to really understand the metastatic breast cancer patient population, to understand what we as a society understand about metastatic breast cancer, to understand how physicians and patients communicate around metastatic breast cancer, and understand what happens in the workforce for metastatic breast cancer. And so we initiated a program that was really in three phases, and it began really with research around what even are the words that are used in describing metastatic breast cancer, and what are the understandings in society at large. Because as you guys are probably very acutely aware, a lot of the language around breast cancer is all around cure, and it's all around early breast cancer and the outcomes for patients who are diagnosed at an earlier stage. And that language, I think we all can attest to, has resulted in a bit of a misperception around breast cancer as a whole. And in order to better understand what the needs were, we basically undertook a research program that had three basic aims, and they're listed here. And what we did was conducted research both into understanding society's awareness about metastatic breast cancer, understanding what happens in the workplace with patients with breast cancer, including metastatic disease, and then also trying to understand communication between physicians and patients. And the way we did this was actually we videotaped patient and physician interactions and interviewed physicians and patients after those interactions occurred, and evaluated the language that was used in the interaction, the understanding of the patient. And this isn't, the findings are actually not novel to breast cancer, but I think they're particularly poignant in regards to breast cancer, just because of the disconnect that we observed in those communications. And I would start simply by covering some of the insights that were gained through this research program. And the first is that the methodology was really very robust. It was an online survey of over 2,000 adults in the United States representative of socioeconomic, geographic, educational backgrounds that were very diverse. And then we explored the patient-physician conversations between 22 metastatic breast cancer patients and their community-based oncologists. And some of the insights are not going to be surprising to you all because you are very aware probably of many of these issues. And so patients in general felt they had an understanding about breast cancer probably because of a lot of the activity around early breast cancer and activities to promote research fund resources as well as fundraising efforts. And so all of those elements contribute to the feeling that individuals have an understanding. However, over 60% of those people said they had no or very little understanding about metastatic breast cancer. And then when we dig deeper, we understand that the misperceptions are actually fairly significant. And 72% of those patients believe that advanced stage breast cancer is curable if it's diagnosed early, and that 50% believe breast cancer progresses because patients either didn't take the right treatment or didn't do whatever preventative measures they should have taken. And then 41% believe that people with metastatic breast cancer can live a long time. And so those were obviously very, very telling pieces of information. We also found, and I'm not going to walk through the whole research program because then the whole talk would be about that. But I want to just summarize a little bit about the insights about physician-patient communication. And one of the things we discovered was that the language that's used by the physicians I would say underrepresents the severity of the disease, and words are used that are like instead of disease progression, activity of disease. And in talking about bone disease, there's discussion about helping preserve the strength of bones as opposed to a direct discussion around the site of disease. And then talking about the fact that the disease is incurable, instead the words are used that we can talk about it in a chronic context. That's not to say that for some patients that isn't possible, but for the vast majority of patients today it isn't. And so what happens is a disconnect in the communication and a potential for misunderstanding and also expectations that are misaligned with what the physician then can offer to the patient. In addition to which, we did a workforce evaluation of over 1,000 women with breast cancer, and roughly 15% of them had metastatic breast cancer, to understand, and also then we interviewed employers as well, and to try to understand what's offered for patients with metastatic breast cancer or breast cancer diagnosis in the workplace, and then interviewed the patients and tried to understand what their perception was. Not surprisingly, there was also a disconnect there, that the employers thought that there were resources available and support available, but the patient's experience was different from that. And we also uncovered that many patients, and actually disproportionately patients with metastatic breast cancer, wanted to remain in the workforce and found it important as a part of defining who they were and a sense of normalcy and opportunity and future for them. So these are all elements that helped inform what did we do next with that information. So we found a lot of insights. How do we then go forward to try to improve these areas of disconnect? So we basically initiated a public awareness program, and part of that I think most of you may have seen, or some of you may have seen, at our Story Half Told booth that we have here this afternoon, and that we've tried to have present at most Komen events and at events for other advocacy organizations, as well as events around breast cancer in general and oncology in general, trying to help spread the understanding of the metastatic state, metastatic condition, and challenges with vocabulary that's used around them and common misperceptions. And with that, we've also initiated basically a social media presence around Story Half Told, and this is something that's present through Facebook, Twitter, and Instagram. And there are posts from participants who are actually, I think we have a participant here today, Sheila McGlown, and I'm not sure, Sheila, if you want to identify yourself. There you are in the back. And these are folks who have identified themselves as being willing to participate in something like this. And what happened was we had a photographer, a group of photographers, sort of chronicle the lives of these folks and basically have that information as part of a social media campaign to help spread awareness, understanding, and information. And it's actually in very little digestible snippets. And actually there was a really nice one today on Instagram in International Women's Day. I don't know if you saw it, Sheila, but I think it's made an impact, and I encourage all of you to check it out if you haven't or if you're not already aware of it. And there's also other initiatives in trying to address communication challenges with physicians and also workforce or workplace disparities. But I want to also transition into a couple other areas to give you a bit more understanding about things that Pfizer has done, both growing out of this research as well as our commitment to breast cancer as a whole. I should also credit all of those who partnered with us in the Story Half Told campaign and research. So I didn't mean to gloss over that. All of these folks and organizations were critical in getting this program up and running and helping to sustain it. What I wanted to also emphasize is that these insights also demonstrated to us the significant disparities that exist within the delivery of care. And one thing I found very interesting from what Dr. Benho Park said is in regards to his virtual tumor board that is going on internationally, one of the real challenges we have in the United States is the disparity in delivery of care, access to care, and the quality of the care that's delivered. And so Pfizer has partnered with the NCCN, which is a National Comprehensive Cancer Network, in two different quality initiatives. One we did in 2015 and the other we just completed in 2017. And these are 2-year grant programs. And the intention of the first one, and that's the one that I have up on the screen now, is trying to optimize metastatic breast cancer treatment through medical education and healthcare system-based approaches. And so these were requests for proposals. So we put out the opportunity for healthcare systems to apply for grants, and we received over 100 letters of interest to actually then submit. And then we had an independent review panel headed by the NCCN group, typically with Dr. Gratishar, who's here from Northwestern. And we had a group of physicians and advocacy organization participants to look at these grant programs and then make selections. And then we awarded 10 different projects after reviewing 23 full proposals. So those programs initiated then in the following year, and then we will now this year, actually in a couple weeks, meet to understand what did they learn through the execution of these initiatives. And these are in very diverse programs nationwide, trying to improve these topics that are listed here, whether it be gaps in treatment sequencing, whether it's effective communication. There are a spectrum of programs that were initiated. And in order to get funded, these programs had to be what we called scalable, meaning they had to be something that wasn't just a one-off. In other words, there's no real benefit. Obviously, there's a benefit to the individuals who are served when a program is piloted or studied. But we don't want to just be, I was going to say something that my son would say, so I stopped myself because it was going to be vaguely vulgar. And I do that sometimes when I don't mean to. But he would say, he's pissing in the wind. If you just do something and, there's a benefit to a small group of people, but you can't do anything with that. It can't then be rolled forward or can't be scaled up. So we really looked at all of these programs to try to understand, were they scalable? Because if they're not sustainable and can't be sort of propagated, or we can't learn from them, they don't have as much value, and the use of that money could be better spent. So all of them had to have that element to them. So we'll learn more about the outcomes of those projects, and then we also did an initial one, a second one this year, or in 2017, that we're awarding and contracting now, and they'll have the next 2 years to complete the execution of these grants. And again, we had an overwhelming response. And what we tried to do here is recognizing that the access to care is very, very disparate in this country, and not just to metastatic care, but care for breast cancer in general. And there are many reasons why that's true, and they're probably as heterogeneous as all of us sitting in this room, and probably all of them have local idiosyncrasies as well. But we have geographic disparities, we have access disparities that are socioeconomic, we have cultural issues that prevent people from seeking care. And so we're trying to identify commonalities and trying to find opportunities to bridge those gaps. And in fact, one of the granted proposals in this cycle is basically executing the virtual tumor board idea in a rural environment, which is Nebraska, where many patients are hundreds of miles from a tertiary care center or a research oncology center. And so we basically say, well, there's no reason why we all can't be the beneficiaries of a virtual tumor board. And everybody can't benefit throughout the state of Nebraska, or for that matter, throughout the country, from worldwide expertise in these in the care of metastatic breast cancer or breast cancer as a whole, simply by connecting people virtually. You don't need a physical presence of a patient in order to conduct a tumor board. And so all of this needs to be generalized, and we need to be able to share and communicate and sort of get away from the siloing that happens with the way medical records are actually treated too, which is a bit of a soapbox of mine, in the sense that when you go to a physician, your medical record is the property of that care delivery system. And so if you want to then go to a different physician, you've got to request your records. But if you take your ATM card, whether you're going to Wauwatosa, Wisconsin, or Fairbanks, Alaska, or Moscow, Russia, you can get your own money out of the bank with the ATM. But if you went in the hospital in any of those three places, nobody would know what had happened to you in any of the other locales. And this is an infrastructure problem, and it's a resource problem, and it's something that the banking system did because money was put into it. Now there's proprietary electronic medical record systems that function to basically continue the siloing, because each of them have their own proprietary activities. They don't communicate with each other. They don't have common fields. Many of them are not written in order to communicate with each other. So as a consequence, we're perpetuating an environment where we have silos of information that doesn't allow for the best delivery of care. So in order for Dr. Ben-Ho Park to see you, if you're not in the Hopkins system, you're going to have to get your record sent to him, instead of having your record as part of something that you already own or have responsibility for. Regardless, all of those are ways in which we can improve the delivery of care. And one of the things that Komen is working toward, as they've stated, is their bold goal. But what I would postulate is it's possible that we could get a lot closer to that bold goal than you might imagine if we dealt with some of these fundamental challenges, even in delivering the standard of care that's available to everybody who has breast cancer and has or specifically metastatic disease. So I think there's some what you might term low-hanging fruit in terms of identifying the problem, but solving the problem is more complicated than you might think. So those are just points to ponder in regards to how we view the problems that exist when we try to say, okay, how do we transform the lives of patients with metastatic breast cancer? There's a spectrum of issues that have to be dealt with, and I think I've highlighted a couple here. But then I want to pivot into the idea that fundamentally we have to have innovative research and drugs that are able to treat identified areas, whether it be an opportunity through the immune system, triggering your own immune system, or part of the cell cycle, as Dr. Park was describing. We have to be committed to the development of those drugs. And so this is the research portfolio that Pfizer has currently active in regards to the breast cancer space. And we have basically, somebody mentioned earlier, the CDK4/6 inhibitor, and then we also have a PI3K mTOR inhibitor that we're studying, and a PARP inhibitor. A PARP inhibitor works to deal with the BRCA mutation, which is, interestingly, in talking about germline versus somatic, these PARP inhibitors actually work for patients who have germline mutations. And what happens in that circumstance is that the DNA because of the BRCA mutation can't be repaired. It has a strand break mutation, and DNA has two strands. and both of them have to be repairable when mutations occur. If someone has that single strand break mutation and we introduce a PARP inhibitor, that cell line is very vulnerable because it already has a damaged DNA mechanism. And so PARP inhibitors are something that there is now a single PARP inhibitor that's been approved to treat patients with BRCA positive metastatic breast cancer, and that's been identified by an approved test. So that's just happened in 2017. Prior to that, even though we knew about BRCA mutations, there was no action we could take to treat someone who had a BRCA positive tumor or who had germline positive BRCA testing. Now that's changed, and we actually do have something that we can do to treat it. So the science is at a bit of an inflection point. And when we say that, what we mean is we understand way more about the cell cycle than we ever have. We understand more and more about the immune system and how to take advantage of changes in the immune system to try to trigger our own cellular immune response to try to manage mutations that have occurred. Because our cellular immune response is functioning day in and day out to identify mutated cells that aren't functioning normally, and our immune system cleans them up and disposes of them, and we don't get sick, we don't get cancer. Oh, so okay, sorry. No problem. So anyway, so just to quickly pivot from that, so and through this we also have unrestricted grant program with a foundation in order to make all of these molecules available to study any areas in breast cancer, so that if a researcher wants to use one of these drugs, or they're actually early development molecules, some of them, they can be utilized in that research program as well. This is just the phases of drug development, which is complex and somewhat prolonged. And we could also talk a bit about the role of the regulatory authorities in terms of getting these new drugs out to market, because there's things we can do to accelerate that as well. And I think the Cancer Moonshot Initiative has tried to spur some of that as well. And breakthrough designations, which are ways to accelerate the drug approval process, has also occurred. I just want to then highlight one other thing, that the importance of collaboration. And when we say collaboration, a lot of times we're talking about academic community collaboration, industry collaboration with researchers and so forth. But the fundamental missing piece in that collaboration historically has been you all, which is the patient. And fundamentally, we are trying to change that by involving patients from start to finish in clinical development programs. And this is an initiative that's really gotten off the ground over the past 2 years. And I have to stop now. It's like what's going on? Oh, sure, no problem. And so that's something that we've worked very diligently to involve patients in, and we've got a program in place now that allows us to do it in a much more efficient fashion than we have in the past. And we've learned many different insights that we've been able to improve this clinical trial design by virtue of incorporating, after reviewing whether it be a protocol design or clinical endpoints, with both advocacy organizations and individual patients. And so with that,
thank you so much. Sorry, it's the room. So I'm now honored to introduce Shirley Mertz. Oh, I'm so sorry. Okay. We're now going to view a video from Odnate, and then we'll hear from Shirley Mertz. Thank you.
I'm Karen Durham, currently a stage 4 metastatic breast cancer patient. I was originally diagnosed in 1989. They did the biopsy on this one place, and just a couple of days later, she took both of my hands and she said, "Karen, you have stage 4 metastatic disease and we'll fight it with everything we can." That's when I lost it.
I'm Joyce O'Shaughnessy. I'm a breast cancer oncologist here at Baylor University Medical Center. My practice here at Baylor is Texas Oncology, and then I do my clinical research activities through Baylor, through Texas Oncology, but also through the U.S. Oncology Clinical Trials Research Network around the country.
The main thing that people don't know about clinical trials is they think you're a guinea pig. You're not going to get real treatment. That is not true at all. you're going to get the standard of care treatment regardless of which arm you go on. You're going to get standard of care, but there's a huge chance that you're going to get more than the standard of care.
Clinical trials always aim to take the best standard that we have and add to it. It's not a substitute for standard therapy. I've been working with Odinate since the inception, and I'm on the steering committee for the Contessa trial, so I've been working with them fairly closely in the development of the protocol, etc. So I'm impressed with the speed that they're moving along, and it's a small company, but they're launching this big global, phase 3 trial. So I'm impressed with their determination and dedication.
When we were asked to do a review from Odinate, we reviewed their phase 1-2 information and their protocol for the phase 3. I think it was a wonderful experience. I think every pharmaceutical company should reach out to the patient advocate community and get experienced patient advocates. That new drugs get approved is through clinical trials. And if people do not participate in them, there's never going to be any new drugs. If there's never any new drugs, there's not much hope for long-term survival.
We need more tools against this disease. We don't have this thing in the bag yet.
It may help me, but if it doesn't help me, it may help somebody else out there. I'm not in this just for me. Yes, I want to stay alive. I desperately want to stay alive. But I don't want my daughter or anybody else's daughter or son to ever hear, you have breast cancer and it's metastatic.
Women invariably take to the idea of contributing to the next therapeutic strategies that are going to make the next advances for the women to come. They fully get it, that their therapies that they're receiving today are basically entirely due to the women that went before them who raised up their hand to participate in the clinical trial, because that is the only way we make progress that is accepted.
The research that's going on, the cutting edge research, and also the clinical trials are what give me hope. I'm not ready to die.
I am more hopeful now than I ever have been in my 30 years in oncology, and I hear that from all of my colleagues.
I'm way beyond the normal life expectancy of when someone's diagnosed metastatic. I do believe that the clinical trials have given me a huge boost in that area.
Just wanted to say thank you to Odinate, one of our sponsors, and now here's Shirley Mertz.
Thank you. I want to say good afternoon. I am very, very pleased to be here, and I do thank Komen Chicago for hosting this metastatic breast cancer conference, and we do look forward to more services and programs in the future. Before I begin my presentation, I just want to reach out to the patients in the room, because right now you've kind of been invisible to me and to others. If you would be so kind, and it's your choice, would those of you who were diagnosed 1 or 2 years ago, please raise your hand. 1 or 2 years ago diagnosis? Okay, we have several. And those of you who were diagnosed 3 to 5 years ago, would you raise your hands? All right. How about 6 to 10 years ago? All right. And how about those who were diagnosed 10 or more years ago? Okay. Well, I really applaud each and every one of you for coming here today. Our most precious commodity as metastatic patients is time, and you have chosen to spend your time here today. And I hope that when you leave, you feel that it was worth it. My goal today is to share strategies that empower each of us to get the best care to optimize our chances for living long with a good quality of life with the complex subtypes that make up our unique metastatic breast cancer. I began my relationship with breast cancer in 1991 when early stage in situ breast cancer was discovered on a mammogram. It was hormone positive breast cancer. I was told I got it early and offered a lumpectomy with radiation. Instead, I said I want a double mastectomy. I wanted to be cured, and that's what I had. 12 years later, though, in 2003, metastatic breast cancer was found in my spine. I was prescribed an anti-estrogen therapy by my local community oncologist, but 6 months later, a scan showed that my disease had spread throughout my skeleton and into my liver. I was troubled, confused, and scared by this rapid disease progression, and frankly, I was less confident in my doctor. Though I feared I would make my doctor angry, I decided to seek a second opinion at a comprehensive cancer center, the University of Chicago, even though it was far from my home. There, a biopsy was ordered so that the molecular makeup of my disease could be determined. Pathology reports showed that my metastatic breast cancer was ER/PR negative and HER2 positive. That was very different than my early stage hormone positive breast cancer. I was offered targeted therapy by the oncologist at the University of Chicago, and 10 months later, there was no evidence of disease on scans. I was shocked, but very thankful for those results, though I was told that I was not cured. I am still today in the treatment. In retrospect, however, mustering the courage to get a second opinion saved my life. When I had that dramatic outcome, I decided then to devote my time to use my voice and story to inform others about the importance of a biopsy and how the right tests can inform the right treatment. Since 2005, my advocacy has led me to participate in several groups and organizations that address the challenges and needs of our metastatic breast cancer community. A description of my advocacy, if you're interested, is included in your program. So getting a biopsy and the right tests on our tissue and blood, not only upon diagnosis, but also upon progression, is a valuable strategy for ensuring the best outcomes. Metastatic breast cancer can and does mutate. My disease mutated again in 2014 and caused me to have a change in treatment. Molecular changes can be driven by the cancer cells or by the very treatments that we take. A pathology report is crucial to determining the right treatment. What I experienced at the University of Chicago was personalized medicine. Today, the term, I believe, is precision medicine, when the genetics of the tissue or tumor are looked at. That precision medicine involves ordering the right tissue and blood tests and looking at molecular markers to inform and plan the best treatment for each individual. While many patients are treated at their local community cancer center because of travel concerns, as I did initially, I believe that seeking a second opinion at a comprehensive cancer center should be considered when you experience a progression. At comprehensive cancer centers, metastatic breast cancer research is conducted, and there, experts focus on treating many metastatic breast cancer patients, and they normally are up to date on research. In Illinois, there are 2 comprehensive cancer centers. The Robert Lurie Comprehensive Cancer Center, where we are here today, and the University of Chicago. If you live outside of Illinois and are here today, you can find an NCI designated center in your state on the internet. Comprehensive cancer centers will help you set up an appointment and get your records sent directly to them, usually at no cost to you. And your current doctor should not take it personally if you seek a second opinion. If he or she does, you don't have the right doctor. Another strategy to consider when seeking optimal care is learning about clinical trials, which Dr. Lin was speaking about, and Odinate video talked about. We should really look at clinical trials that relate to our subtype and location of metastasis. Every treatment, as you heard Karen in the video, approved by the FDA for metastatic breast cancer, began as a clinical trial. And without trials, there will be no treatments for us when we progress. Since clinical trials can be a form of treatment for some patients, and trials can result in access to new drugs or new classes of treatments, I suggest that you look at the trials you might qualify for if you progress. If your doctor has not spoken to you about trials, raise the topic with him or her. So how can you find easily trials for your particular type of metastatic breast cancer? Let me show you a search engine tool that was developed by a group called breastcancertrials.org. Okay. In this trial search, you enter the location of your metastatic disease and your zip code, as well as where your site of metastasis is. You click on Show Trials, and I'm trying to use this, and as a result, you receive a list of trials that are pertinent to your situation. What is so fantastic about this search engine is that the language that you receive about the clinical trial is easily understood by those of us who are not scientists. And if any of you have gone to a site like clinicaltrials.gov, you know it can be very, very difficult to understand. Nurses and navigators and caregivers and even doctors, some of whom may be in this room, can also use the breastcancertrials.org website, where they can also look in a more advanced way for trials that are pertinent to their patients. So in summary, the strategies that I have shared with you all relate to gaining knowledge about your disease, your subtype, and your treatment options. It takes effort to stay on top of your metastatic breast cancer, but knowledge is power. And armed with knowledge, you can and should actively participate in your care decisions, considering your doctor's recommendations while taking into account your personal values and preferences. And always ask questions. Finding information and resources has been made easier by the Metastatic Breast Cancer Alliance, which quickly I want to just tell you about. It was founded in October 2013. The Metastatic Breast Cancer Network, which I lead, and Komen, our host today, are members of the Alliance. There are 33, here are the logos, 33 breast cancer organizations who said by their agreement to join that they would devote resources on their website about metastatic breast cancer, and that they would work to progress research, offer information and services to patients, and through a task force called an awareness task force would raise issues important to the metastatic breast cancer community. I just have to tell you, and I know I'm a lot older than many of you in the room, but when I was diagnosed in 2003, I couldn't find anything on the internet because it just didn't exist. And now you can look at any of these organizations, and there's information for you to use. Okay. Finally, I just want to let you know of an initiative that the MBC Alliance will announce or launch in April of 2018. It is an interactive online patient registry, and I urge each of you who are metastatic in the room to join that registry. Your data will be de-identified, and it will give you an opportunity to partner in research. You'll answer surveys about your disease history, treatment, and quality of life, and then researchers, scientists, and clinicians across the country can access your data, and you will receive updates about what they find. So in closing, I hope that, and this could be a whole nother presentation, but we don't have the time, is that I urge each of you to use your story, your talents, and passion to advocate for three important things in my view. One, we need increased private and public funding for metastatic breast cancer research. Secondly, we must have access to health care that is affordable. We cannot let people destroy our health care system, or we will not have a future. And finally, I urge us to demand treatments that go beyond progression-free survival, but rather produce overall survival so that we can live a long time. I thank you for your attention, your privilege of being with you, and I wish you all well.
Hi, everyone. I'm Catherine O'Brien with the Metastatic Breast Cancer Network, living with metastatic breast cancer since 2009. And if you have had the disease for a while or are newly diagnosed, I think you'll find something to relate to in this video. Thank you.
Getting to know you, getting to know all about you, getting to like you, getting to hope you like me, getting to know you, putting it my way, but nicely. You are precisely my cup of tea. Getting to know you, getting to feel free and easy. When I am with you, getting to know what to say. Haven't you noticed, suddenly I'm bright and breezy because of all the beautiful and new things I'm learning about you. Day by day, getting to feel free and easy, getting to know what to say. Haven't you noticed, suddenly I'm bright and breezy because of all the beautiful and new things I'm learning about you.
1, 2, 3.
There's
There's a dark and a troubled side of life, but there's a bright and a sunny side too. Though we meet with the darkness and strife, the sunny side we also may view. Keep on the sunny side, always on the sunny side. Keep on the sunny side of life. It will help us every day, it will brighten all the way, if we keep on the sunny side of life. Though the storm in its fury broke today, crushing hopes that we cherish so dear, clouds and storms will in time pass away. The sun again will shine bright and clear. Keep on the sunny side, always on the sunny side. Keep on the sunny side of life. It will help us every day, it will brighten all the way, if we keep the side of life.
Thank you for sharing that. Dr. Cherie Prentice is next. She's going to introduce herself, but she is the national spokesperson for the Coleman African American Health Equity Initiative and former ambassador for our 3-day. Dr. Cherie.
Good afternoon, everyone. As Amina stated, yes, I am, actually, I'm a 10-year breast cancer survivor. I think that's what I'm most proud about. I did serve as the national spokesperson for the Susan G. Komen 3-Day for 6 years, and now I am the first African American national ambassador for Susan G. Komen's Health Equity Initiative. I am also author of When Everything Changed, My Journey from Physician to Patient, and I am also founder of the Live Today Foundation, which is a 501c3 organization that seeks to do 3 things. 1, educate physicians about the psychosocial impacts of lymphedema. And no, I'm not trying to be Michael Jackson. This is a compression garment that I decided to bling out because I figured if I have to wear it, I might as well look cute. And secondly, to educate lay people that no, you don't need to sit back and be satisfied with the fact that at least you're a survivor and this is just some swelling that you deal with. I lost my entire clinical career because of lymphedema. So to educate lay individuals about the importance of treatment, and then finally to provide free compression garments to individuals who cannot afford compression garments because of financial difficulties or who are permanently unable to provide themselves with compression garments. Now, the shared reality of cancer has caused us to band together and come up with ways that we can increase access and to find better treatments and to find a cure. However, the nuances of our individual struggles and triumphs often go unlooked. So as part of my next book project, I'm looking to share the full experience of the Metaviver's life. So if there were some of you that visited the table that was next to Juzo, you saw this simple two-question little survey. If you are interested in participating, this is just a teaser. You don't have to worry about filling everything out, but if you are interested, I really want to hear your story. I want to be able to share with the world your story. All of my panelists will be a part of this next project because it's important. People think that, life goes on. They walk past us on the street and, never even know the stories and the lives that we are living and the struggle that we're going through. But it takes something to be able to face the world without this chip on your shoulder, without carrying your world on your shoulder. And the world needs to know that and understand it so that our caregivers and our co-survivors, our co-workers, they know how to deal with us. They understand our perspective. So please, if you're willing, please raise your hands. My colleague and editor will provide you with this questionnaire. Right now, what we really just need is your name, your email address, and your phone number. If you're willing to take a part of this, is very important. Now, I have a fantastic panel today. And what I'm going to do is I'm going to introduce each panel member, just tell you a little bit about them, ask them one specific question about them so that you can keep them in your mind. And then after everyone has had an opportunity to answer at least one question, I'm going to throw out some general questions that each of them will get to respond to, and then we'll have time for Q&A afterwards. Is that all right? All right, I'm going to start with my beautiful lady, Miss Shannon. Shannon is married. Her and her husband, Kevin, they have a nice little rescue dog named Madison. Shannon was first diagnosed with breast cancer in 2015 with stage 3 triple negative breast cancer. She was only 26 years old. She is a carrier of the BRCA1 mutation. Shannon's grandmother died from metastatic breast cancer at the age of 38. And Shannon's mother was diagnosed with breast cancer while Shannon had received her initial diagnosis. Now, Shannon had chemotherapy, a double mastectomy, and thought that she was cancer-free. However, 2 years later, she learned that the cancer had returned in her lymph nodes, and she was now living with metastatic breast cancer. Now, she's AAA. Can you give me a deal, get my car towed? No, she's triple negative. And that's about 15% of individuals who have breast cancer. It is typically aggressive, especially amongst young women and African American women. And Shannon's breast cancer is hereditary. And unbeknownst to most people, only 10% of breast cancers are actually hereditary. Now, Shannon, raise your hand, baby. Look at that beautiful lady. Now, Shannon, I want to ask you this. Can you tell us some of the challenges of facing a metastatic breast cancer diagnosis at such a young age?
Well, first of all, I'm really happy to go first. I'm going to throw that out there. I guess kind of similar to just the video that we just watched is that I look so young and healthy. I still work out. I still go to work. And people can't get over the fact that I have cancer, let alone metastatic breast cancer. So they say the same thing. You look healthy, you look great, your hair, like, what's going on? You don't look sick at all. When, in fact, I'm a little sick. So.
Exactly. Now, next I want to introduce to you Shanette. Shanette, raise your hand, baby. Foxy thing. Shanette is a single mom of 2 boys, 11 and 19, and she was diagnosed with metastatic breast cancer that spread to her liver and her spine just prior to her 34th birthday. She is HER2 positive, and HER2 positive individuals only make up about 20% of breast cancer diagnoses. She recently turned 39, and her cancer, while not curable, has been found to be stable. Now, HER2 positive is a more aggressive form. Initially, she received targeted therapy in a clinical trial and followed later by a mastectomy, radiation, and reconstruction. She is now getting some targeted chemotherapy to manage metastases in her liver and spine, and hormone therapy for small tumors in her other breast. Now, Shanette, my question for you is this. You've been dealing with this disease. I know you have had many ups and downs for the past 5 years. Can you share with us some of your coping strategies and how you have managed to maintain such a positive outlook?
Just continuing to get up and go. For me, it's a control thing. Just staying in control. Just trying to live. It's a new normal, but still keeping it normal. Still getting up and taking care of my kids and still going to work. Just still being as normal as possible and not letting cancer take control.
Awesome. Catherine, who introduced that wonderful video. That, unfortunately, although there was humor in it, it was right on point. I hear it all the time. Now, Karen, for you men out there, is single. She was diagnosed with stage 4 breast cancer in 2009 at the age of 43. She's been in treatment ever since. She worked for about 5 years after her diagnosis, but recently, over the past couple of years, she stopped working. She has the most common subtype of breast cancer, ER positive, ER, PR positive, and HER2 negative. That occurs in about 80% of individuals with the breast cancer diagnoses. Now, Catherine, she was metastatic from the get-go. So, and for 8 years, she hasn't had chemo yet. And she is truly a great testimony. Her mom died from inflammatory metastatic breast cancer at the age of 53. Now, Catherine, my question to you is, you are on your, I think it's your 5th line of treatment now. How do you deal with the anxiety of scans and, like, in 4 instances, progression where you've had to change treatments?
Well, I find drinking helps. No, I think, as with anyone, you have to say, how do I feel today? You can't think about, what happened previously or what might happen, or else you're going to miss out on what's happening right now. And I think for me personally, information is a big coping strategy for me. Jeanette used the word control, and although we don't have a lot of control over our disease, knowledge is something I feel like I can control, and if I feel if I'm as knowledgeable as I can be, that helps me combat a lot of the stress and uncertainty.
Awesome. And then we have Robin Page. Robin, raise your hand, love. Robin is married with a daughter and a son. She is 48, and she was diagnosed with stage 4 at the age of 39 back in 2008. She's been living with metastatic breast cancer now for 9 years. She's been off all treatments since 2011 and continues to be stable without a return of cancer. Robin, my question for you is this. Were you treated for early stage disease and then had a metastatic occurrence, or did you start with metastatic breast cancer?
So, no, I was diagnosed with metastatic breast cancer, so I had spread to my lungs, and then I was HER2 positive as well and started on Herceptin. And as I said earlier, had a good response pretty quickly. And then made the decision, after a lot of knowledge, as Catherine said, to discontinue treatment. And always thought if I needed to go back on it at a certain amount of time, I can. And I've just been stable without return of disease since then.
Awesome. And then my last person on the panel, Dr. Lynn. Dr. Lynn, I got a question.
Wait, you're not going to say how old I am, I'm hoping.
No. You better be glad that I don't know, because I sure would have, because I'm sure you do not look your age. Can you tell us why is it so important for there to be diversity in clinical trials?
Absolutely, and I because I was so meandering and long-winded, I didn't get to that part of what I wanted to share earlier, which was that this is a critical component of what we in the pharma industry need to do, as well in partnership with all the patients as well as advocacy and academic institutions and so forth who actually are the clinical trial sites, is make sure that we are doing whatever we need to so that participants in clinical studies actually represent the people who have the disease in actual life. If in fact what we do is study patients who have a disproportionate racial makeup or ethnic heritage, then when the drug maybe get approved and is out in actual use, we may actually not know how effective it will be in the population who actually has the disease and struggles with it. And just a case in point, for example, if you think about just going away from oncology for a second to hypertension, which is really disproportionately severe in African Americans, if that population is underrepresented in a clinical trial and we think we've got a great new antihypertensive drug, but in fact in actual use it doesn't work well in those people who are struggling with it. Likewise, if African Americans or Asians or Latina patients are not represented in clinical trials, then the results may be difficult to generalize to the people who actually need to use those drugs. So we are fundamentally tasked with making sure that whomever is participating represents who's out there,
Who's receiving the drug.
Who's actually struggling with the disease.
Now my next question is this, and I want the Medivivers, if you feel comfortable, answer first, and then Dr. Lynn, I would want your perspective. And the question is this: how can we change the delivery of care for people living with metastatic breast cancer? What can you see that we can do in the field of medicine in changing how we deliver the care that you need? Any questions? Any responses?
Sure.
How can we train? And it may be educating physicians and having them, spend more time to understand the nuances. And instead of just saying I'm clear, maybe it's to ask me, how are things at home with the husband and the kids, whatever it may be.
I think that's a broad question. I think I would look at that in terms of specific areas. For younger women, like Shannon on our panel, oftentimes these women are misdiagnosed because the median age for breast cancer is 61. So if a woman her age goes to a doctor with a complaint, oftentimes there can be a delay in diagnosis. So that goes to educating sort of all physicians. And then I think beyond that, I think that many of our oncologists, because they see so many early stage women, they don't really know of resources for people with metastatic disease. So I think just general resources. And then I think finally, the language of cancer is one that very few patients speak. When I was first diagnosed, I went for my first set of scans, and my oncologist said, "I'm going to restage you." And I thought, well, maybe they were wrong. Maybe she's going to restage me because I don't have stage 4 cancer. Well, it turned out restage you was oncology speak for, I'm going to send you for a set of scans to see how well this medication is working. And so I think just, language is a big issue.
Language. Thank you. Anyone else? Dr. Lynn, do you have?
I just think that's a very important point, and one of the things that we uncovered in the project I was referencing earlier, that the communication skills of the average oncologist are actually not very good.
Mm-hmm.
And one of the things that I think is important is that the professional organizations for physicians training and fellowship should incorporate communication skills. And if someone is pursuing a fellowship in oncology, presumably that's because they want to deal with people who have cancer. Therefore, they need to understand the vocabulary, what the language means, and how to communicate and how to listen. And I can say this about us because I'm one of us. I mean, I think in general physicians do a poor job of communicating, and surgeons do a really poor job, and I'm one of those, so I'm allowed to say that. But in general, there's a huge gap between what the physician believes they said and what the patient understands.
Correct.
And this is something that's solvable. Communication skills can be taught. This isn't an inherited thing like blue eyes or blonde hair.
Mm-hmm.
This is a trainable skill set, but yet, here we are in 2018 still talking about something that should be a fundamental issue.
Correct. Robin.
I also think it would be nice to walk into an oncologist's office and be a whole person. Not just our disease or not just where is your disease, but talk to us about nutrition. What other options are available? Are you exercising? How is that going? Find out all the other facets of our life that go on that contributes to where we are currently.
Got it. Next question. Can anyone comment on your level of support or lack thereof from your community, from family, when you were given the diagnosis, and what has occurred over the last few years since your diagnosis?
I'll start. I, in general, have amazing support from family, friends, coworkers, my company. They're very flexible, so that's a huge win for me. I think the only thing that is still difficult, and so it's been almost exactly 1 year since my metastatic diagnosis, is explaining what metastatic breast cancer is. As a patient, most doctors tell you don't go too far in the black hole of the internet when it comes to cancer, because you will come up with articles that tell you to eat more asparagus or don't eat asparagus and all these crazy things. But I was more surprised that close family and friends jump on Google and learn what metastatic breast cancer was, and that I had to be the one to explain the difference between stage 1, 2, and 3 and stage 4, which is kind of just in a whole nother category. So that was like the only hard part with my support system, was explaining. That to them.
Okay.
Yes.
Anyone else want to comment? Jeanette?
My support system has been awesome. My family, which I have someone here today, my mom, and when I'm like this, they didn't really ask me a lot of questions because in the beginning I was unsure. I didn't know what was going on, but instead they did the research for themselves and they learned about the disease on their own, which made it easier for me. So for me, that was huge. Just like when I was diagnosed, it wasn't my cancer; it was everyone's cancer. Everyone became a part of supporting me and being there for me when I needed them to be there.
Wow. Awesome. Anyone else? I know. Now, tell me this. I think I'm going to say that one because that could get juicy. How have you emotionally handled your progression? Yes.
Well,
Drinking.
we covered that one. I think it depends. Yeah. Yeah. So I think it depends. The first progression that I had, it was upsetting, but not perhaps as upsetting because at that time I had bone-only metastases, and so I had further spread to my bones. But I was on tamoxifen, so it meant moving to Femara, which was, not earth-shaking, shall we say. I think the most difficult thing for me was when my previously bone-only disease spread to my liver, and not only that I had been on 4 drugs, and the previous 2 had failed. So first of all, liver metastases was a scary proposition, not just because it could potentially cut into my drinking, but because because people can often do well, with bone mets. People can often, not always, people can often do very well with bone-only disease, with bone mets for a long time. But when you start talking about, well, now the cancer's in your liver, that was very scary to me. It was sort of a whole new thing. And then it was also, to be honest, it was frightening when I looked at, previously I always felt like, I have a really long list of drugs, but now I had, moved through the anti-hormonal drugs, and, I was pretty much knocking on chemotherapy. So that was very frightening. I took a page from my colleague Shirley Mertz. I got a second opinion. It was hugely helpful to me because that was also taking control. I was upset, but going for that second opinion gave me more information, and it also made me feel like, well, I was doing as much as I could. I was learning as much and going for, getting additional insight. So I guess it was very difficult, but, I found others' examples inspired me, and I found also that I could, more information helped me see my situation more clearly.
Has living with metastatic breast cancer changed your risk-taking behavior? I know for me as a survivor, I have branched out and have done things I never would have thought to do just because the finality of when I went through my diagnosis and treatment hit me, and I just thought, if not now, when? And I wanted to do things that would leave a legacy. So I consider myself legacy living now. Has the diagnosis and living with it changed your risk-taking behavior? Investment strategies, jumped out of a plane, something like that. Anyone? Or if there's no change, then there's no change. But I think that's a question that people would want to know. Has it changed the risk you're willing to take?
Yeah.
Oh.
And how much? This is going to sound crazy, but I'm a very type A person.
No.
I love working 40+ hour weeks. I like going to as many events as possible, family friend events. So the first time I was diagnosed in 2015 with stage 3, I continued to work the 40-plus hour weeks, go to every family party, every friend's birthday, just tried to keep up. Well, I've had a complete life change in the last year, and this to me is a risk. Like, I've learned how to put myself first, not work 40-hour work weeks, because that's crazy. Go to a lot of yoga, and mostly because that's just something that I love and enjoy, and, you know, again, putting myself first and learning how to say no to people. No, I'm not coming to your birthday party, and I don't even care if it really offends them that much.
I love it. I love
Because
it.
you can only just do so
much.
And I'm just learning how to, like, spend time where I want to spend my time.
Wonderful.
But I also would love to jump out of a plane, and my mother's here, and she'll kill me for saying that.
Anyone else want to comment how it may have affected their risk-taking behavior?
I'll make a quick comment, and that was I really dislike getting my picture taken. So when Ford Warrior Models of Courage was looking for some people in Chicago, I was not a natural person to do this, especially because I had to get my picture taken next to Shanette. And
gorgeous.
Shanette's modeling career has blossomed. My phone is not ringing, but it was something different. It was definitely outside of my comfort zone. That's really not something that I would normally do, but I enjoyed it more than I thought I would, and I have somewhat become Shanette's agent. So if you are looking for her to be at your cancer events, see me, 20% off the top.
Now, did any of you seek any complementary forms of treatment? And if you did, what worked for you and what didn't? Yeah, Robin?
So when I was first diagnosed, I did the thing that you're not supposed to do. I went on the internet and I started reading. First, after I got over being, okay, why me? I did feel bad for myself momentarily, and then I said, all right, I am where I am, so what am I going to learn? And I reached for everything. I tried SCACT, I tried this. Oh, this might help. Okay, I'm going to try that. Okay, this might help, and I'm going to try that. I think as the years passed, I boiled down to really changing my mindset. My thoughts and my words matter. And practicing yoga, practicing meditation, trying to be in the moment and stay in the moment, and not think, what if I had done this, and not think, okay, where am I going to be in 5 years from now, and where are my kids going to be? So I try to stay here. I do take some supplements now. I, at one point, was taking a lot, and I've narrowed them down to just a few now that I work and sometimes tweak and sometimes change those around too. But I've done acupuncture, massage. I make sure I get outside and walk. It's all part of kind of me being whole and who I am. I think I responded to the drugs, and I think that that's also part of keeping me here, where I am, and speaking to you guys today.
Awesome. Now, our panel has been absolutely fantastic. We now have an opportunity for a few minutes of questions. Does anyone have particular questions of our panel? Feel free. As you can see, they're an open book. They will tell you whatever it is you want to know. Oh, yes. Please, right. Oh,
we got one behind me?
Right behind you, sweetheart.
So, Robin, I'm interested in what supplements you do take now.
So right now, mostly turmeric, vitamin B12, because I currently eat a vegan diet, vitamin D, and then I just added a kind of a gut, I don't remember what it's called.
Like a probiotic?
No, I take a probiotic, and then it's called glutamate.
Oh, okay. Yes, glutamate. Glutamate.
Glutamate?
Yes.
So, but at one point I was taking, I can't even tell you over the years what I've taken, but that's kind of what I take now. And it's doable. I also am not very good about taking supplements twice a day. So I will tell them, if you're going to give it to me twice a day, don't, because I won't take it. I take them in the morning most of the time when I remember. And then if I forget in the morning, then I don't take them until the next day. So.
Okay. Jasmine, did you have a question?
I do, and actually I'm going to yield back to you because I am really curious what that juicy question
that you were going to
Oh,
table to
the
ask.
juicy
so
question.
I'm going to
Okay.
give you the floor back
Okay.
to ask that question on my behalf.
Okay, here's the juicy question. What has, if anything, changed regarding intimacy? For, told you. I'm thinking.
Would you like that?
No.
No
Well,
one.
I'll answer.
Yes.
I just got married, so.
Thank you. I knew she was going to jump in.
I'm trying to keep things spicy still.
Yes.
Well, first of all, in 2015, I was on TAC chemo, so Taxol, Adriamycin, Cytoxin, and I went through premenopause, so I lost my cycle for, 10 months. Oh, freaking menopause is the worst.
Yes.
Hot flashes, would wake up soaking wet sheets and not in the good way. Had no sex drive, so my mom's here again, just so you guys know.
That gorgeous lady there.
So it was hard for that 2015 period, and then slowly sex drive came back. This time around, so I'm on a PARP inhibitor. I've been on the PARP inhibitor since mid last April. And that was paired at the beginning in a trial with cisplatin, and cisplatin actually didn't affect it as bad as the first type of chemo I had. And now just on the PARP inhibitor, 0 problems. So
Yes.
super happy to report that.
Are there additional questions?
No
yet?
one else wants to answer that question?
You'll answer. Okay, come on, Shanette. Looking this gorgeous. Come on.
For me, it was because I did have a mastectomy. I only had one breast removed. I didn't have a breast for 2 years. So after that, I had reconstructive surgery. So it was just getting comfortable with my body again. I mean, and even now, I only had, just the one side done, and I did have an implant on the other side, but I'm still I'm still not even. So for me, it was just feeling sexy again and getting comfortable with the new changes, with the new body.
Fantastic.
Look at her now.
I know. With an agent and everything. We got a question here? Oh, here. I'm sorry.
Okay. I do some complementary stuff like Qigong, which is like Tai Chi, and to try to be, take care of myself in that way. But I would not credit that for still being alive almost 3.5 years after my diagnosis with metastatic breast cancer. So I'm just kind of curious, Robin, are you crediting that kind of stuff for your continued survival or your medical treatment?
I think it's part of it. I definitely do. It's the $1 million question. Did I respond to the medicine that I did, or did I respond to the surgery, or was that part of it? Is me being me who's part of it? I think it's a whole. I don't think I break it down as much, but I'm at the point where I'm not willing to test those waters of kind of going back to, eating a diet I was eating before. It's working for me right now. So I think it's part of it. Is it all of it? I can't say. I just don't know.
One more question here.
Sure. You might not be comfortable with this question, but if you are, then I ask that you please answer it. Did you guys seek out any support from a psychologist, a therapist, and if so, was that encouraged by your medical team? And did you find it beneficial being a psychologist myself? It's just a question that I'm curious about.
I can answer. I did. My husband and I went through the Cancer Wellness Center. We did, I think it was like an 8-week program together. And then we took our kids there as well. I'm a physical therapist, so I'm very open to helping myself. So that was an important part. My healthcare team did not refer me. I was, throughout my whole treatment, been a real big advocate for myself and needing the knowledge and the information that I needed to make a decision. And that was definitely part of my healthcare team of what I needed.
unfortunately, we're running out of time, so we're going to do one little quick comment.
Hi. I want to thank Dr. McRoy for mentioning me in the story Have Told. And that was one of the reasons I did a story Have Told, is because of racial disparities, and to show African American women that, and all women, that just because you're living with metastatic breast cancer, you could still talk about it and you could still feel beautiful. And I felt that was very important for me to get that across to the African American community, because we don't participate in clinical trials. We don't do, just yesterday, my daughter called me and said, "Ma, the lady at the church, she feeling a pain in her breast and she won't go to the doctor because she don't want to know the results." And this was from October. Wow. So it's my job, and the past 8 years I have been an advocate and been in my community saying, hey, we need to talk about it. We need to go into churches, and we need to do. Churches is our foundation, as everyone knows, and it's our culture. My mom died of metastatic breast cancer, and she did not talk about it. And when I got it 5 years later, I knew nothing about breast cancer. So 2020 is hindsight, but I wish, I don't even know what type of breast cancer she had. So, and mine was HER2 positive. Didn't even know it was 6 types. So it's important for all of us as a community, as a breast cancer community, to go into communities like ours, to talk about it and to say, hey, this is what's happening with breast cancer, and we need to do more because racial disparities do exist.
Exactly. Let me quickly wrap up. Our panel has been absolutely fantastic. Some of the takeaways that our panel wants you to understand and appreciate is that sometimes it's become very important to them, and the burden falls to them to explain what metastatic breast cancer is. Sometimes you're going to have to take on that responsibility of explaining what it is to your village. They support with the lack of support that some of them receive, they had to do research on their own, but then with some of them, their family became such an advocate and did some of the research for them, so that their metastatic breast cancer became a family diagnosis. And lastly, learning how to put yourself first and knowing how to say no and not caring and being okay with it. Janice Williams, would you please stand up? Please, if any of you are interested in sharing your story in my next project, please grab a form, put your name, address, and not your physical address, your email address and your phone number, and someone will be in touch with you. Please give it up for the fantastic panel. Thank each and every one of you.
So I'll be really quick. And don't forget, I have a little raffle to hold you hostage a little bit. But I do want to do some thank yous, because as you can see from that little box over there, that we don't usually have money to put on conferences like this. 75% of the money goes to our community grants, 25% goes to research to try to help advance these treatments and find a cure. So without our sponsors today, we could not have put this event on. So I would be remiss if I did not thank Pfizer, Odinate, and Merck. So thank you so much for your sponsorship. Thank you, the physicians that came, our volunteers, and of course, our fierce, fabulous foursome, our committee, Dr. Cherie, Shirley, and Catherine, and Robin. I'm gonna put her on the spot for a second. Yes, thank you. This whole thing was planned by the 4 of them. And I'm gonna do just a quick, I'm gonna pick on Robin in a second, but I'm just gonna do a quick call to action like my girlfriend, Jasmine Johnson, likes to do. I'm going to encourage you all to act, donate, and get involved. However you want to do that, however you want to be a patient advocate, like our sister just said up there, use your voice, help another sister out if you hear about a diagnosis, and do something like Robin did. Robin, how she met me and Bonnie was she sent her an email, and not a happy email. She's like, she called her. No. And then she invited her to come and have a sit down. So Robin came to our office all the way by O'Hare with a list of questions. What are you all doing about metastatic? What about you all push screenings and mammograms? What about people like me? And she called us on it. She was absolutely right. This is the first time we've done a metastatic breast cancer conference, and it was because of her. So again, thank you. We appreciate that. And then some surveys just went out, and I realize it's really long, but we want to make sure that we capture and we want to put our money where our mouth is and make sure we did this right and can continue to build and improve on it. So thank you for that.
And thank you to Amina, because she really has taken this on. And really, thank you. We hope to do this again, make this an annual event, make it bigger and better next time so we don't have to run out of here at 5 o'clock. And again, just be well. Everyone here, be your own advocate, get optimal treatment, and be well. And we just hope to see you next year. And to Dr. Park, thank you so much. We are so grateful.
Matt, you can stop the recording for our live stream, so they don't have to see this. They don't have to get jealous about these 3 raffle prizes that we're going to give away. But 4 raffle prizes. So I'll be really quickly. And again, this